300,000 worldwide of children born with severe anemia, and the implementation of preventive and control strategies for inherited anemias has not been widely adopted globally. This map shows the newborn with sickle cell anemia. As you can see, the highest incidence in Nigeria, Congo, and India, and as a Saudi Arabia, we have a significant number as well. This study, local study, showed the high prevalence of sickle cell anemia in Eastern region and South region, including Jazan and Asir. Regarding thalassemia, there was a data analysis was obtained from premarital screening, showed the overall prevalence per 1,000 population was 13.6, of those 0.7 were beta thalassemia disease. This map showed the G6PD globally. As you can see, our country, one of the highest prevalence country all over the world. So the early diagnosis, it will lead to timely intervention and reducing complications. The WHO estimate about 70% of sickle cell disease mortality could be prevented with the implementation of early diagnosis and intervention programs. The traditional screening ways, it can miss some cases, especially post-transfusion and alpha thalassemias. So there is a modalities to detect the inherited blood disorders. The traditional methods, as we learn in the medical schools, start by clinical history, including the symptoms and family history and premarital screening if it was done or not. Then the clinical signs in form of pallor, jaundice, organomegaly, then specific blood test. But the traditional way, it can miss the diagnosis of asymptomatic patients because they are not coming to the clinic. And of course, it will lead to late diagnosis and suboptimal comprehensive care. So for that reason, we should innovate new modalities in screening and early detection of inherited blood disorders. So one of the modalities is newborn screening programs. It will lead to markedly reduced morbidity and mortality through the early diagnosis and parental education, especially for vaccinations and prophylactic penicillin that lead significantly to reduce the pneumococcal infection. And of course, it will end with the comprehensive care, especially the early initiation of hydroxyurea and stroke program. The newborn screening program for sickle cell disease, it was globally adopted in US by the end of 2006. All the 50 states include sickle cell disease and newborn screening. In Europe, many countries, especially UK, France, and Spain, Germany, and others. In Saudi Arabia, I will skip it later on. The other modality is telemedicine, including virtual genetic counseling and telehematology virtual services. It will help to access to specialized care and reduce preventable complications and death. The other modality, by remote screening technology, by using mobile health applications that facilitate the early intervention and ensure the continuity of care, especially for the area that hard to reach. Also, other modality is cloud-based electronic health record system. It will facilitate the referrals across the different levels and promote evidence-based decision-making, and it will ensure the interventions such as blood transfusion, hydroxyurea therapy that documented and optimized. The other modality is point of care and digital health innovation. It is a low-cost modality. It can be implemented in rural area. It provides a rapid test within 10 minutes. The equipment is highly portable, such as Gazili and sickle scan and others. But the all positive result should be confirmed by second sample and documented in the medical record. The other test is next generation sequencing, which is the most advanced genomic approach for the screening of hemoglobinopathies. It is highly sensitive and specific. It will detect all the non-pathogenic variants with multiple samples can be sequenced in the single run, so it will save the cost. It will detect the novel mutation, but the only disadvantage, it is high cost. The other modality, advanced modality, is a CRISPR-based diagnostic technique with the advantage of rapid turnaround time. The result may take 30 to 60 minutes with minimal equipment requirements, so it can be portable and used as a point of care with high specificity. But the only disadvantage, it is still in the experimental phase, shown only in the pilot studies. Okay, so allow me in the coming few minutes to talk about our project in Saudi Arabia. So the newborn screening program of inherited blood disorder in Saudi Arabia, led by Blood Disorder Administration under the umbrella of Ministry of Health. So this program was started since April 2023, including sickle cell disease, thalassemia, and G6PD, added to the other metabolic disorder that in the national newborn screening. So after a lot of meetings and reviewing the references and discussing with other expertise, we adopted the MOH protocol for positive cases of sickle cell anemia, thalassemia, and G6PD. This protocol is clear, and it was sent officially through the email of Blood Disorder Administration to all MOH hospital. So every hospital, they should run and follow this protocol. Add to that, with the cooperation of Sahha Virtual Hospital, we initiate a special virtual clinic. We call it Inherited Blood Disorder of Newborn Virtual Clinic, with cooperation of Sahha Virtual Hospital. Me and I have a special nurse, Sister Najwa. They're collecting the data, communicating with the parents, and taking all the data, including the ID, contact number, and she is booking the patient in the clinic. So with the aim to assist the positive cases, provide health education to the families, apply treatment protocol, as well as follow-up for the patient, and referral to the nearby hematologist or pediatrician in the local sites. Regarding sickle cell trait and G6PD, since we have a lot of numbers, so we initiate the SMS messages. It will be sent to the mobile number of the parents, including the educations for G6PD and sickle cell trait, and they have the right to visit any MOH institution for further information. Also, we have expert team doing the monitoring and follow-up. So we have Ms. Lina, she put a dashboard with all informations for monitoring and to create a report monthly and from time to time. Sorry. So this data, as you can see from the dashboard, including all the details that it was done, including the positive cases, the sickle cell trait, how many messages was sent, G6PD, how many cases booked in the clinic, and how many patients seen and started the medical protocol. This dynamic dashboard from time to time we are use it. So we reached till the this important slide. So it shows from the beginning of the project till the end of December last year, we reach, and we are proud to announce that we test more than 751,000 baby for inherited blood disorders. With the positive cases was almost 9.2%, about 5% was G6PD, 3.8 sickle cell trait, and 0.15 sickle cell anemia. And as you can see here, we draw the map, Saudi Arabia map, we know that most of disease patients from Jazan, then Eastern Province, then Mecca, Riyadh, and so on. So hoping, inshallah, for by the end of 2026, we'll reach screening for 1 million baby for inherited blood disorder. So if you allow me for a few minutes, this is the screen, and a lot of effort was done behind this screen. So from starting of the nurse at peripheral hospital, how take the first drop of blood of the baby, put it in the filter paper, filling the data, send it to the central lab, Wiqaya. Our colleague in Wiqaya, they collect the samples, they run the samples and give us the result, send it to the blood disorder administration, they filter it and they send it to virtual clinic, they send SMS to the G6PD and sickle cell trait. So all of this effort are appreciated. Add to that, our colleagues as pediatric hematologist consultant in different areas who start the medical protocol and follow the patient now. So all this effort is appreciated. And because of time, we cannot mention all of them, but it is a must now, if you allow me to mention only one person, since the first day of this project till now, this person, she is the real leader, real mentor, and real supporter for all of us. So without her effort, nothing will happen. So on behalf of all people who work behind this screen, on behalf of thousands and thousands and thousands of newborns who were included in the registry, on behalf of their family as well, and if you allow me, on behalf of all of you, I want to thank with high appreciation Prof. Hatoun Azzat. Really, Prof. Hatoun, since till yesterday, and she's communicating with me to change, to add, so really, thank you very much, Prof. So, to conclude, the inherited blood disorders still causing significant morbidity and mortality. Early detection and management improve the quality of life. Advancement in biochemical, molecular, and AI-driven methods, it will enhance the early detection, and need to standardization of protocol that implement of early and of quality control and measures. Future research focused on optimizing cost-effective screening strategies and integrating AI, more efficient diagnostic, and encourage community education and engagement for a better health for patients with inherited blood disorder. And I guess this summit and the others, one modality to encourage the community to hear from the others, and of course, by indirect way, all of us will leave after 3 days, will teach our community. So it's the end of my talk, and stay with us to enjoy the next session. Thank you.
Thank you very much, Dr. Faiz, for the excellent presentation. The next talk will be with Dr. Muhammad Shaheen about the premarital screening. Dr. Shaheen, Executive Director of Non-Communicable Disease and Healthy Lifestyle in Ministry of Health and Public Health Authority Department. Please, Dr. Muhammad.
السلام عليكم، حياكم الله جميعا. Muhammad Shaheen, Executive Director of Healthy Lifestyle and Non-Communicable Diseases at Public Health Authority. We will present today innovation in screening and early detection of inherited hemoglobin disorder the role of premarital screening programs. I will present on behalf of my colleague, Dr. Suha Slimani. She is the supervisor of Healthy Marriage program. Okay. We will talk about the significance of the program and the counseling services we provided and pathways for healthy marriage, also the impact of the program and statistics. The role of genetic counseling and premarital screening. Inherited blood disorder represent a significant public health challenge in Saudi Arabia, and genetic counseling and premarital screening are essential preventive services or measures to reduce the burden of diseases. These interventions support informed decision-making while respecting cultural and social values, and prevention is advanced through science, digitalization, and outcome-driven healthcare approach. Overview of the inherited blood disorder in Saudi Arabia: 56% of are contiguous marriage, contributing factor to genetic disorders. 1.45 to 4.65% is the prevalence of thalassemia and sickle cell anemia in premarital screening. Genetic counseling addresses psychological aspect, family communication, and other very important aspects. The significance of premarital screening in Saudi Arabia. Premarital screening is a comprehensive national program established by royal decree in 2004. The program is mandatory for couples prior to marriage. It aims to decrease the burden of specific infectious and hereditary blood diseases, decrease financial burden on family and the community, mitigate the psychological and social problems faced by families of affected children, and the program promotes awareness of healthy and safe marriage practice. In the premarital screening, it includes different health services, starting from performing premarital screening to identify the presence of certain hereditary blood disorder, sickle cell anemia and thalassemia, and some infectious diseases, HPV, hepatitis C, HIV, and syphilis. Also provide health education and premarital counseling, and provide preventive measures as vaccinations. What is the definition of safe marriage? In every marriage case, either both parties or at least one of them be free from hereditary blood disorders covered by the program, regardless of whether the other party is carrier or affected by condition. Unsafe marriage, both parties are either affected by or carrier of hereditary blood disorder covered by the program, or one of them is affected while the other is a carrier. For the certification, if both parties unaffected, they will get the certificate. And if one party is a carrier while the other is unaffected, or one party is affected while the other is unaffected, they will refer to the counseling clinic. And all cases of infectious diseases are considered safe marriage with adherence to preventive measure of issuing the certificate. If both parties are carriers of the disease, or both parties are affected by the disease, or one party is affected while the other is carrier, they will refer to the counseling clinic, and they have the choice to canceling the marriage or attendance educational sessions, then they will get the certificate. So compatible cases receive a premarital screening certificate, and incompatible cases are referred to specialized counseling clinics. Our strategies in prevention of hereditary blood disorders, starting from national awareness by annual public awareness campaign on the National Day of Healthy Marriage, also educational outreach through pre-screening health education and post-test counseling to provide support and guidance based on screening results. Also targeted approach through specialized educational program for couples found to be at genetic risk, facilitating informed decision making, and also innovative technology implementation and integration of HMP in primary healthcare. From traditional to innovative screening, traditional screening relied on limited test panels and paper-based workflow. Innovative screening used advanced diagnostic and digital end-to-end pathways. Also focused has shifted from the number of tests performed to measurable health outcomes. Adoption of high-performance laboratory technology such as HPLC and capillary electrophoresis, and also improve differentiation of hemoglobin variants, implementation of standardized national diagnostic algorithms, and enhance quality assurance through accreditation and automation. The premarital screening program has been fully transformed into an electronic platform, and integrated digital functions include online appointment booking, barcode-based sample tracking, automated result reporting, and secure certificate issuance. Digitalization has significantly reduced duplication, errors, and waiting times. Also for couples who decided to proceed with marriage, an educational program has been designed. It consists of 3 sessions after counseling. The first week, health education session, detailed insight into SCA, sickle cell anemia and thalassemia, and their transmission, symptoms, and prevention option. And the second week, we will provide emotional insight sessions. Couples watch movies despite the struggle and suffering of families and children affected by these disorders. And for the third week, support group session, interaction with families who live with these disorders, allowing for an authentic perspective and support. These sessions were designed based on qualitative research, including focus group and interview with health professionals, counselors, and couples, ensuring a well-rounded approach. The scope of genetic counseling: first, comprehensive genetic counseling begin with a comprehensive assessment of family history to identify inherited risk, and for the carrier testing is used to identify individuals who may carry genetic disorders. And for the family support, couples receive information on reproductive and preventive option to support informed decision making, and couples also receive an information on reproductive and preventive options to support these measures. Genetic counselors provide comprehensive services. They help families understand inherited patterns and make informed decisions about genetic testing. For expanding and expanded future ready screening, the premarital screening program has been expanded to include optional screening for additional genetic disorder, and this screening is optional for Saudis, which include 5 genetic diseases as shown in the slide. The national and strategic impact: approximately 1% of premarital cases are identified as genetically incompatible. From the starting of the program until now, we screened more than 6 million and annually 300,000 tests in 492 premarital screening centers. And the percentage of cases of hematological diseases detected for sickle cell anemia, 4.55%,
and thalassemia 1.42, HPV 0.63%, hepatitis C 0.13%, HIV 0.03%, and syphilis 0.01. 99% of premarital cases were genetically compatible. Only 1% were identified as genetically incompatible, and these findings demonstrate the effectiveness of early screening and counseling. And also the patient satisfaction has shown a constant and sustained improvement over time, and the satisfaction increased as shown here from 76% in 2018 to over 90% in 2025. And this reflects improvement in service quality, digital access, and turnaround time counseling experience. Conclusion, the program play a vital role in reducing genetic disorder like sickle cell anemia and thalassemia, improving the quality of life of our citizens, and alleviating the economical burden on our healthcare system. And we stand committed to the continuous improvement and expansion of these programs, recognizing their integral role in shaping a healthier future for our nation. Thank you.
Thank you very much. We're going to move on to actually using new technology of the future. And I'm very, very really privileged to introduce a very distinguished person, Dr. Mariam Al-Aissa, who is a distinguished leader in genomics, precision medicine, and health innovation. She's worked with many leading universities and institutions like MIT and Harvard. She's widely published, and she's been given national awards, the Princess Abdulrahman Prize for Women's Excellence in Health Innovation Research, and was honored by Her Royal Highness Father Al-Hidlain for her leadership in transforming healthcare through innovation, data, and strategic vision. Dr. Al-Aissa, we are inviting you to come and speak to us. And congratulations for all your achievements.
Assalamu alaikum wa rahmatullahi wa barakatuh. It is my great pleasure and profound honor to be with you here today to present a topic which is always dear and near to my heart, genetics and innovation related matters. I would like to thank Dr. Hatoun, who's always supporting in genetics since I was in Wiqaya. She tries so hard to introduce the program to the newborn screening. Thank you so much for saving lives. I think Dr. Faiz, he didn't leave anything for me. He stole some of my slides unintentionally. However, I'm going to talk about the foundation and urgency. Why do we need a new technology or techniques to investigate the hematological diseases or common or rare hematological diseases? It is widely spread. I think I'd be so humbled to speak about hematological diseases in front of hematologists. You already know most of the things about it, more than I do. However, in the state itself, from 70 to 100,000 individuals affected by sickle cell anemia alone, where it's only one disease of number of diseases of hematological disorders. And it's critical. It's, as my previous speakers said, it's need an early detection, early intervention. So when blood goes wrong, whether it's the cell itself, the membrane, or any component within the cell, from a single point mutation which change sickle cell from one amino acid, glutamic acid, into valine, it creates a clumping of the blood cells. This is very important. This is the fuel of life. I'm going to talk about the things that I know, the thing that I did in the past few years. So we did a publication with the National Guard Hospital with my that time colleagues, Dr. Majid Al-Fadl and Ahmed Al-Faris, who give me the reservoir of data that they have, and we did the analysis to check the carried, the most carried variant or disease within the Saudi population, utilizing 1,300 database that they have of exomes, and we found that the top on the list is hematological diseases, with number of genes that associated with the Saudi population that represent in our database. We compare it to the Saudi genome database, and we found it very common in our population. However, it's ultra rare in other populations. So the consequences of delay add a lot of, let's say, burden on the healthcare, on the individual, on the family who's caring of the patient. The treatment require early intervention. So having the result early would help a lot of people. Considering that not everyone privileged having a good healthcare system like Africa and other countries where they need a point of care techniques that help them. The genetic component is a big part of it. However, the complexity landscape of the genetics vary from one country to the other. So the pool of genetics that present in African population is not the same in Arabic population or in other population. The methodology that have been used, like blood smear, it's not enough to define all the diseases, especially the rare one. Also, the delay would cause a huge impact. So how this revolutionized through the AI and new technology. Sorry, I skipped the slide. So the classification currently, according to the WHO, mainly focus of identifying the phenotype and correlate it with the genotype. If we're going to talk about the common genetic variation, or let's say sickle cell anemia and thalassemia, we know the gene, we know the mutation. However, for the rare and ultra-rare diseases, or hematological diseases, this is really challenging, especially that the test we provide currently, even a new, the one we use in premarital, is the biochemical testing. It's not always the answer for all the diseases that we require an answer for. The profiling, before or previously we used the microscope to identify morphology of the cells and check how accurate, let's say, or expert the person who's reading the slides, but it's not always the case in different diseases. So if I'm going to talk about the next generation, it's already there. It's not a novel thing. However, for the rare mutation, we have different new platforms like the long read. As Dr. Shahri mentioned, we have a CRISPR-Cas technology which exists as a point of care for a number of diseases. The value of accumulative knowledge, when we have in 2006 a few mutations associated with certain genes, with certain diseases, now we have a bigger number, and this is from 2019. I couldn't even download the 2025 because it's so big. There's many correlations with diseases, or let's say a polygenic effect where certain mutation involved in many diseases already assigned, and we know them. So from the single point mutation, and I think some of the hematological disease affected by the environment or the nutrition that been taken, the basic, let's say, understanding of the genetics, it's a single mutation with or without environmental factor. It can cause the disease. So in the case of most of the hematological diseases, it's monogenic, where a single mutation follow Mendelian inheritance can be prevented, and it can interact with environment or not in other cases. And this knowledge will help us in detecting pathways and also detecting the best gene therapy for each disease. If I'm going to talk about complex, which is not always the case in hematological diseases, however, it have a different pattern of inheritance. Number of mutations with or without environmental factor causing the disease, and from there you will have the phenotype. And the only way to prevent it is by understanding the complexity of the disease and avoid the environment. Point of care, there's many. Using the AI technology, we have a lot, and I'm going to talk about tools that we already create, and it can give a rapid result and it can reduce the delay. However, when you talk about the sequencing itself, it's expensive. However, then that can be replicated in the pathway and the biology, and from there we can find the biomarker that assess the diagnosis. So from the variant interpretation that we use in genetic analysis and the prediction models that we have, and the global access to different platforms where we understand the association with mutations have been, let's say, observed or identified in different regions, and this accelerate our finding or our, let's say, diagnosis. AI have been utilized in precision imaging analysis for the morphology of the cell, and also maybe if it's for infected cells like malaria and others, it is the counting and is the let's say single cell involvement in certain diseases, where it's also have a predictive model. As you can see in the figure, where it can precisely identify the difference in shape, the count and everything, which we used to have 2 or 3 hours to look into the smear to identify certain things and give the right count. It can be correlated with other factors. Maybe luckily we have Nafis nowadays, and maybe in the future we can integrate it to the healthcare system, and from there correlating the biomarkers that we have with wearables, with others, this will accelerate the process, let's say, of diagnosis and prognosis as well. From machine intelligence, with the phenotype and genotype and others, we can predict or precisely create a twin where it have all the information or the measurables that we have from the healthcare record into the person, let's say, digital twin platform. From there, personalize the diagnosis, personalize the treatment, personalize the medication and the prognosis of the diseases. I'm going to talk about a tool that we create with Al Faisal University with my great colleagues who still dear and near to my heart. We are a family now, creating a company, a startup, which we have it as a company now. It's called Precision. Precision identify or diagnose diseases, rare and complex. I started with psychiatric diseases because it's my topic and my, let's say, subspecialty. And we awarded awards, we publish, we go to conferences, we present it in a lot of places, we award fund for it, we publish a number of papers, some of them still ongoing. We also develop the, still developing the tool into pathway analysis and finding the best medication. We award a prize of Jameel AI in medicine, which was a privilege. So what we do, we calculate score of the diseases. For monogenic, we can easily identify it from the database existed. We can, it's a simple integration with different databases and platforms. For the novel things, not trained yet for it, to be very fair and honest. However, for the already exist, we have it. The unfortunate thing about it that we tried it on Caucasian population. So the first sample which run on this is my sample. I told my students, especially we started with schizophrenia and bipolar. I said, if I'm schizophrenic and bipolar or depressed, never tell me about it. And they were happy trying to find something against me. Unfortunately, they didn't. But I told them it's still unsure because we used Caucasian population. Maybe when we screen in Saudi population, the result will change. We did a pipeline in the front end. You put your DNA, or let's say the whole genome, whole exome, which we preferably use. We look into the back end where we link it to different databases, and it will process and give you your result or scoring. The scoring will be cluster of things, and it's still prediction. Prediction is not always, let's say, very accurate, but still it will give you an indicator. But if there is a disease, we will assure that we can find the diseases. It's easy and friendly user based on live databases, stable, it's in one place. The disadvantage, if there is a single point mutation, misalign, it will crash the whole thing. The limited computational power, you need the computational power to run it. So if there is number of samples or number of data, it's going to be difficult. It's require time to, let's say, evolve, but it's under R&D. We have papers, we have things you can look at it. Does DNA give you all the answers? No. In certain things, we have translational effect or transcriptional effect. It cannot be found in the DNA. This is why we have no explanation for certain diseases, even if we have the genetic component for it. How we can create an ecosystem where we create a tool, accurate tool to understand, let's say, the pathway disrupted, and from there we can target the metabolic or the transcriptomic or the proteomic and find the right tool. It's require research. So from number of people that we can use and analyze using different platforms, we can assign certain pathway to certain organ, to certain disease, to a certain mutation, and from there we can biohack the system. Gene therapy is one of the example of biohacking. I'm not going to talk about it because we use it in creating a diagnostic tool. But what I want to emphasize is not always we look into the gene itself, because as we did with the Cas-JV, we're not targeting the HPP gene. We target the gene that's associated with fetal hemoglobin. It's just activating the hemoglobin that have been not activated after adulthood, and biohack the system, or let's say tricking the biology and try to activate and restore the function of the cells. I'm not going to talk about Cas-JV, but however, the costs and these things, we talk about it a lot, but there is a lot of drawback. The cell toxicity, the treatment complexity, it's not always the answer. This is why I would emphasize prevention and early intervention prior. How we can rewrite the genetic code, or from the experience that we discussed or the knowledge that we have, clinical trial is very important, looking into different diseases and hematological diseases, what's common in our population, not in others, and this is why we need to have, let's say, our own study and our own research competing in an advantageable way with the global research market. Dr. also Shehri mentioned the integration of technology, whether if it's platform or digital connectivity through virtual hospital. All these things can be linked an advantage of accelerating the innovation and an advantage of the patient. Further, which also I would like to emphasize, I don't know if the time will help me, why we are doing this, or let's say all these things. And if we look into it in a different way, trying to, in a lot of blood diseases, we do bone marrow transplant. So here we did the research with the Takhassusi, King Faisal Specialized Hospital, where we look into a database of people with a lot of hematological diseases to look into why they have, or some of the patients who did the transplant have chronic graft versus host disease. So we're actually submitting a paper about genetic insight shaping the bone marrow transplantation outcome in the Saudi population. And I emphasize the Saudi population, and I highlight it and I put it a red tag, because when we did this research, we thought we were going to find something correlated with different population, which is not. We did not find the same. Only one mutation, we share it with the worldwide in this research. Well, I would emphasize my team, who I worked with them in the past year, Dr. Abu Huda, Dr. Tariq Weda, and Dr. Nada Tasan, who give me a lot of support on this research to do the analysis. So we look into the global database, we look into the genes associated with hematological diseases, we look into pathogenic and lycopathogenic variation, we analyze, or let's say we extract them, and we find 150 variants that might associate with bone marrow transplant failure. And we look into the same genes in the Saudi population, which is different, completely different. Only one variant are the same. So this is very important in let's say, not only diagnosing patient prior therapeutic, prior having, let's say, decision to take a transplant from anyone, even if it's family member, to screen genetically, to look into if he's compatible or really compatible or not. There's a huge failure. I think you know better than me on this. You treat patients with a lot of hematological diseases. The transplant is not always a success plan, but it's good to know the genetic variation that might do to this failure. Because as I mentioned in the first paper that I presented, we are, most of us, carrier, especially in the Arab population. We are carrier to something related to hematological diseases. So prior transplant, we need to check the donor. There's a lot of ways to do the analysis other than HLA and different things. But if we create a policy for that, that might add value. I'm not going to take so long, but I'm going to give an example on policy where me and Dr. Samar Ikram, who's a very great colleague, and I like working with her because we just have the idea of writing a policy about cancer. We said, okay, there is a breast cancer. What is the prognosis of each gene and mutation globally? This paper is the first paper published ever. Within 2 weeks, it gets accepted and published because it's give a huge value on prognosis according to the genetic variation. I'm just highlighting to give you an idea what can be done, because if we couldn't do it in hematological diseases, please do the same. It's very important. You have the genetic variation, just put a list of prognosis or guidelines to the doctor according to the gene, how we do the analysis. And that's my talk. Thank you so much.
Thank you, Dr. Al-Isa, for the excellent talk about the genetic and inherited blood disorder. I'm glad to present the speaker for second presentation, Dr. Abdullah Zaid. Dr. Zaid is consultant hematologist and the former head of Inherited Blood Disorder Center at Qatif Central Hospital. He's the founder and first program director of Hematology Fellowship at Qatif Health Network. He championed the sickle cell disease pathway in the Eastern Health Cluster for adult patients. He was trained in Ireland and gained the MRCBI and Hematology Fellowship by RCBI. He's the Hematology Service Leader and the Manager of Hematology Development Program Project of Ministry of Health at the Eastern Health Cluster. Dr. Zaid will talk about the disease prediction severity, and I always enjoy your talk and advise you to keep your phone away and enjoy the Abdallah talk. Please.
Thank you very much, Dr. Hafid, for this nice introduction. And I'm so glad to be here. Thank you, Prof. Hatoun, for this kind invitation to be among dear colleagues and friends. So my talk will be a bit fascinating, I would say a bit complicated, but I don't want you to get bored from the beginning. I try to walk you through the presentation as simple as I can, because I need your attention. So to simplify sickle cell disease, it's a polymerization of the hemoglobin S that leads to red blood cell sickling, and then there will be veno-occlusion. But the affection of this will be from the head to toe, where the patient may develop any complication through his life. That's the simplified way. But if you come to reality, the reality is totally different. It's really like entering a maze. The patient may start with a simple dehydration in the right side that gets into very complicated pathway, and you don't know where the patient will go to. The maze is so really complicated, and that makes the life very difficult for those patients. So I don't know as a hematologist where my patient will go through. And most importantly is this part of the pathway where the patient will go very fast in the corner, in the left corner, and these patients will not allow us to save their lives because they will deteriorate so rapidly and immediate death, some of them. So why, if the mutation is the same, why it is not the disease? So if we got two patients, A and B, both of them genotype hemoglobin S and S, both of them the same age, 28, but their fetal hemoglobin F is 5, but one of them will have really 0 hospitalization, no organ damage, active lifestyle, but in the same time, another patient who have the same genotype, the same age, the same fetal hemoglobin, but this patient will have more than 5 admissions per year, will have pulmonary hypertension, avascular necrosis, and chronic pain. So this question is really not a new question. It is an old question. It is decades question. And since the time we knew about sickle cell disease, since 1910, when the first case was published by James Herrick, we got a lot of these. We were trying to know more about the disease. And until 1949, when we knew that this is a problem with the DNA, that this is hemoglobin S there. But we could not really figure out what exactly going to drive the complications of the disease. I think it is sort of a clinical deception, because what we are looking at is basically at the tip of the iceberg. We are looking at the vaso-occlusive crisis, we're looking at acute chest syndrome and the hospital admissions. But beneath the tip of the iceberg, there's a lot of drives and a lot of predictives that, like including the genetics, the haplotypes, the biomarkers, the inflammatory process, as well as the environmental modifiers, in addition to the social determinants. Some patients, they may have low life style and they may have poor income, so their life will not be the same as those who have all the facility. So again, the clinical picture is deceptive. What we treat is the tip of the iceberg, and what we predict lies beneath what we see. We know there is a fire of inflammation, there is hemolysis, there is cytokines production that will lead to tissue damage and fibrosis. And for example, the heme oxygenase 1 is the defense for a lot of cells. And the high expression of this is very protective. But if we fail to upregulate the HOMOX 1, that will lead to ferroptosis and organ failure. On the same time, this will lead to more consequences. And talking about cardiovascular complications, there are a lot of complications that may happen as a result of this. And definitely will lead to heart failure, cardiac arrhythmias, diastolic dysfunction, and so on and so forth. again, back to this maze. If we want to know and look again to this group of patients who goes so fast that we cannot catch them early and then we lost the most of the time, we can really understand how they deteriorate so rapidly by looking at the stages of the painful crisis. And we know that there will be a prodromal phase, there will be an initial phase, and then the plateau of the established phase where the patient will be in severe pain and agony. If we know this, we need to know more extra that there is another biomarkers going hands in hands with this. And an example, the C-reactive protein, the serum amyloid A, as well as the reticulocytosis and the white blood cell count. And these all are markers. If we follow them carefully, we will know which patient is going to deteriorate. So we will know the reactiveness versus the predictiveness of the disease. It's not only this, but also the platelets count, which is really, I find it very important biomarker when those patients get admitted. So there will be a platelets cliff in those patients, and the rapid decline, the more important to look. And even if you start with the platelets normal, if the platelets is normal and drop, let's say, by 50%, and it's still normal, this decline is very important. In addition, of course, to the LDH and other markers. There is another marker which is called the secretory phospholipase A2, which is really being also found that it is predict the impending acute chest syndrome, in addition to microRNA, LIT7, 5P. But we should always keep in mind the other clinical factors, such as the patient who have already chronic lung diseases like asthma, COPD, or they have previous acute chest syndrome, or being only young and with low hemoglobin F. These are all markers to determine whether the patient is going to deteriorate or not. So again, the platelets decline, but also the neutrophil rise up that will tell us that those patients may go and deteriorate so rapidly. So between these high-risk biomarkers and limitations, and we know the inflammatory process, the high leukocyte count, the high hemoglobin because of the hyperviscosity that will lead to, in addition to the genotype, these are all markers for us to know that they are going to do worse. But we always have limitations with this because in a steady state, those patients, you cannot differentiate them. And in between these two, we have the clinical caveat, those patients who develop a painful crisis recurrently, and they have like more than 3 painful crises, but they do not get hospitalized, but rather they are treated at home. So these patients whom also we need to keep attention to them. If you go back to the genotypes, and we know that we have a lot of genotypes, and we look at the hemoglobin F in everyone. If you see, most of them is below 10, but the hemoglobin S and hemoglobin S beta 0 are having the highest severity among them. And hemoglobin SC will be moderate, while the hemoglobin S beta 0 will be mild. And we know that there is individuals who have both sickle cell disease and alpha thalassemia, which is less anemic, and without the alpha thalassemia, will not be seen. So those patients with alpha thalassemia trait, they will have higher hemoglobin. But again, the decrease in alpha hemoglobin chain in the setting of a sickle cell disease was found to reduce the mean of the MCHC, which reduce also the polymerization of the hemoglobin S and the red blood cells. So there will be less polymerization and less sickling. But again, alpha thalassemia co-inheritance with sickle cell disease does not really affect the baseline of hemoglobin F, and the F cell count on those patients will not increase. And we know that there are a lot of genotype, and among them, the hemoglobin, the persistent fetal hemoglobin is the mildest form among all of them. And we know there is like 2 arms where there is a decrease in the nitrous oxide bioactivity. At the same time, we have the increased of the vaso-occlusive occlusion on those cases. And I think there is really 2 main players in this: the hyperviscosity phenotype and the hemolysis phenotype. So there is a bifurcation of pathophysiology. Those patients who has higher viscosity, they're having higher hemoglobin, they will have polymerization. That will lead to more veno-occlusive crisis and acute painful crisis, acute syndrome, and osteonecrosis. On the other side, the hemolysis itself is also another problem that we need to address, because they will have low hemoglobin, they will have high LDH, and they will have nitrous oxide scavenging. And these per se will lead to hemolysis and endothelial dysfunction that will lead to pulmonary hypertension, priapism, leg ulcers, and also stroke. And among these two, we have to know which patient are we dealing with. And back to this, I would say, invalid hypothesis, which is calling the benign Arab Indian haplotype. And actually, if you look to where this comes from, majority of the resources you will find it coming from pediatric literature. And this is one example here, which was published from our hospital in Qatif, where you see the mortality is 0 with acute chest syndrome. They are all pediatric patients. And the mechanism that they propose that they have hemoglobin F with alpha thalassemia prevalence, likely to buffer the pulmonary phenotype in this age group. But is this correct? Well, there is another different opinion. Professor Abdurrahman Sultan, who is from King Saud University, has different opinion with his colleague, that the Arab Indian haplotype is not benign. And he proven this with doing the study that there will be really a paradigm shift moving from pediatric to adult, reveals that the Arab Indian haplotype is not benign, despite of having high fetal hemoglobin. So fetal hemoglobin is not the only player here, and we have other. And that's why those patients from the study he published, there is acute chest syndrome up to 47%, gallstones up to 66%, and persistent splenomegaly and up to 71. So there is really the hemoglobin F paradox, and where there is high hemoglobin F that preserve the splenic function, but it fails to prevent the osteonecrosis and pain crisis in those patients. And you can see that in the graph. So here comes the genetic modifiers. And this genetic modifiers is just like any other diseases. And here I'm giving an example of this patient having a lung disease. There are multiple genetics playing here, and these are really needs to be addressed. So there is a heterogeneity of the puzzle. So it's just like trying to find and solve the puzzle. There is what is called the Arab Indian haplotype. There is a specific beta-globin gene cluster called XMN1 hemoglobin G2 polymorphism. And that's really very important to look at, because the implication that we can go and look for a novel therapy and we can really discover these genetic modifier and find the F cells distribution. And here I'm talking about pancellular, not heterocellular. That really is the key to address. There are a lot of other genetic modifiers, and here I would like to raise this question that is just like any other hematological diseases. And talking about CML, for example, we have TKI inhibitors for a myeloproliferative disorder, the JAK2 inhibitors, acute leukemias, we have FLT3 inhibitors, the BTKI for CLL, and others. There are a lot of inhibitors. Can we really find a specific mutation that we can target in treating sickle cell disease? There is already a preclinical study talking about FLT1 as a mutation that can be addressed, and we can increase the hemoglobin F. And that's really a lot of the other chromosomes and mutations that may also help in understanding the disease and even targeting these point of therapies. Why we are still losing our patients despite of really good screening? And we know that there are patients who are missed. We are doing, let's say, screening for stroke. Our pediatric colleague, they do screening for the complication, but again, it might not be efficient enough. And TCD, the transcranial Doppler done in pediatric age, is really very useful, and it is really can determine what's going on, and also to develop overt stroke. But is that enough? We are doing TCD, but some patients, they still have overt stroke. And when we discover that the TCD flow velocity is more than 200 centimeter per second, this is an alarm for us that we need to intervene. But this is not all the patients will have overt stroke. We have the other type whom they have silent stroke. And this silent infarct is really, which is missed most of the time. And most of the cases, they do not have symptoms. So we do understand that we have two types of stroke. The overt stroke, where there is abnormal TCD velocities with low steady state hemoglobin, there might be a prior TIA. And on the other hand, we have the silent infarct, where there will be less pain rates and also seizure history or even leukocytosis. But we know that both of them, they have the same mechanism. They have anemia, they have cerebral hyperemia that will lead to exhaustion of the cerebrovascular reserve. So again, it is important to prevent stroke, to go through the TCD, but we need really also not to miss those patients who may not have symptoms. And most of these cases, they will have just decline in their cognitive function. They may have a poor performance in the school, and most of the time they might be missed, and that's why we really need to continue and observing and trying to manage them early with doing the transfusion therapy as indicated to prevent the progression. So nephropathy is another way to look at predicting the rapid renal decline. And we know there is already some studies that really look at the genetic susceptibility, like the APOL 1G, 1G2 risk alleles, which is carry 7-fold greater risk of chronic kidney disease progression. And there is also the scoring system, like if there's patient having proteinuria or anemia or having hypertension, as well as reticulocytosis, those patients will be at higher risk to develop also sickle nephropathy. And we have to keep in mind that the EGFR declines very fast, 2 times than the general population, and we have to be carefully screen them. Pregnancy is another problem that we need to look at. And really, I'm using hydroxyurea in some patients during pregnancy, but again, we need to help ourselves by knowing which one really deserves to be continued on hydroxyurea. We know that there is maternal risk predictor, those patients who is having low hemoglobin in the first trimester, those patients who have painful crisis or veno-occlusive crisis in the past 1 year before pregnancy, and those with multiple transfusion in the past. But there is also fetal risk predictors, which is having a younger mother at maternal age, and also having the genotype of hemoglobin SS or S beta 0. And this is not the steady state, but because we have to be dynamically reassess our patients, and the timeline graphic showing that mid-pregnancy is a checkpoint that we need really always to monitor the maternal event and also check for the LDH level. And we know that pulmonary hypertension is one of the very high risk for those patients who get pregnant. But pulmonary hypertension is also have its own predictors that we can also find. So the patient who is having high hemolysis, that will lead to free heme release and also more nitrous oxide scavenging, leading to more endothelial dysfunction. Ultimately, they will develop pulmonary hypertension. But the question, can we predict who is going to develop pulmonary hypertension? Well, we do have some predictors here. Those patients who have TR jet velocity of more than or equal to 2.5 meter per second, elevated proBNP, or abnormal 6 minutes walking test. But again, pulmonary hypertension has another risk factors, which includes the venous thromboembolism. So we know that the patient with sickle cell disease are thrombophilic, so they develop VTEs, and that's basically those patients with severe disease, like having admission more than 3 per year, genotype of high risk like SS or SC, and also the history of previous acute chest syndrome, pneumonia, or splenectomized patients. But again, most of these cases are not propagated from the lower limbs. This is mainly in situ thrombosis, and that's also raised the point that can we predict the VTE in those patients? We did our own trial, like Dr. Al-Isa also did for the genetic testing. This was published a couple of years ago, and we were trying to find, is there any genetic variations on the thromboembolic risk in Saudi population? And this study is done in Saudi. So we did that. We found really novel loci associated with the severity, and mainly 3 main areas in chromosome 9, chromosome 11, and chromosome 20. But that's really still needs to be worked up further in order to know what is the clinical impact to understand and how we can take care of those patients. So integrating all the risk profile, we have found that we have some genetics, and we have the hemolytic part and the viscosity, as well as the inflammation. And every part of these are really carry a risk profile for the sickle cell disease patients. But the question, can we forecast those diseases? And talking about the weather forecast, so no one asked if it will rain, only how likely and how severe and how to prepare when it rains. And we do not really just ask for if sickling will occur or not. We use data to forecast the intensity of the organ storm and to intervene before the damage that happens. Just imagine if we have this storm watch for our patients, those patients who is having inflammatory index high, who is having really hemolysis ongoing and active, and with organ stress level, which is critical, those patients are, we can predict the forecast for those patients to have 80% probability that they will develop pulmonary decline in 5 years. Going to the digital frontier, and we are living, and everybody is having a watch, a digital watch, in his or her wrist. Can we use these really smart devices in order to predict who is going to develop complication? And there was already a trial done there, checking on the heart rate variability, as well as the galvanic skin response, where they can predict roughly whether the patient is going to have pain onset. And that will be really a great area to start with, and we can develop on this. So this is an application called the True Pain Study, the feasibility of using objective physiological markers to predict subjective pain score. Just imagine that this graph's replacing the initial graph that I presented earlier. So we would know where is your patient exactly among these pattern of recognition. In addition, there might be also an application that you can predict whether the patient is going to get an acute kidney injury earlier than the clinical observation. And it is really fascinating getting here into the digital era, where we can add them also in the integrated risk profile for those patients. So again, we need to predict, we need to work on discovering these complications and act accordingly. And those 2 patients who have the same phenotype, the same genotype, the same biomarkers, they are not the same. The severity is not written in the mutation. That single point mutation is not the cause, but really it is written in the clinical and molecular context. And I'm really hopeful that the digital era, that we can make a new risk stratification, getting from clinical and genetic modifier to really having a digital phenotyping that will know our patient, how they are going to behave in their coming years. And hopefully that will really be an answer in the coming few years. So again, clinical deception might be there, but we have to try our best in order to know and what is behind them. And really, what we predict lies beneath what we see, and that how we can really remove the deception from this prediction, and hopefully we can know which patient is going to do worse in their career. And with this, I thank you very much for your attention.
Thank you very much. We're going to have a short period of discussion. So we've been taking through traditional early diagnosis, using new technology, looking into the genomic era and the era of artificial intelligence. The last speaker has brought it all together about being able to predict. And we're going to invite the speakers to come up for our discussion. But I'm going to start off with a controversial thought. Do you think we have adequate interventions even if we predict? Do our patients have adequate interventions to be able to predict the outcomes we are looking at? I mean, you take sickle cell disease and its complex pathophysiology, and yet the molecules we have to treat these children and adults, hydroxyurea, that's it. That's it. We don't have enough in our tools to be able to target these pathways. But we are now entering the era of curative therapy. So I want some of our speakers to comment on that, because what's the use of predicting when you can't do anything about it?
Excuse me, Dr. Demak. Just allow me to invite and thank Dr. Amar Al-Hashim. She will join us as panel member. Where is she? Dr. Amal, please. Thank you for joining us at the last minute. Dr. Al-Hashim, she is consultant pediatrician specialized in clinical genetics and metabolic medicine. She serves as consultant at King Fahd Specialist Hospital, Dammam. Additionally, she is a professor of genetics at Al Faisal University and holds the position of head of the genetic department at Sahha Virtual Hospital, as well as the head of genetic centers in the Ministry of Health. Dr. Al-Hashim is the head of the scientific committee for the birth defect registry in the Saudi Health Council. She has authored over 120 papers and is particularly interested in the birth defect registry and population awareness and prevention. Thank you, Dr. Al-Hashim.
So the question is related to whether we have really enough intervention tools to our patients with sickle cell disease. I'm a very hopeful person, but I have to really look at the real life. What we have are very limited tools. I'm talking here about hydroxyurea, talking about the transfusion, but also the gene therapy as well and stem cell transplant. In my opinion, I still really see the gene therapy is the way to go, but not with the chemotherapy. So the main issue here is the chemotherapy. I would not really, if I'm in the patient's shoes, I would not go to this treatment unless I'm really having no other option to go. So with gene therapy, you are trying to transform the disease, but not curing the disease. But at the same time, I'm harming the patient with the chemotherapy I'm giving. Similarly, in the stem cell transplant. With more recent data that there is now ongoing in the Chinese, if you look in the literature, the Chinese are doing a great job in terms of developing gene therapy that is without chemotherapy or even without conditioning. And it's still in very early stage, in the preclinical stage, and they're targeting the CD45, which is very targeted treatment, so you do not really give chemotherapy. You are only trying to get rid of these cells that prevent the implantation of the stem cells. And that's probably very hopeful news and would not be out or published unless in the coming few years. I'm very hopeful, but what we have at least the present time is not satisfactory to me.
Okay, thank you, Prof. I will talk from the pediatric hematology perspective. So, add to what Dr. Abdullah mentioned. In pediatric patients, still now the hydroxyurea, it is the top. So the other interventions, medications, it is not that effective like hydroxyurea. But for a pediatric population, I think till now the most important issue to predict the severity and outcome is the early detection and education for parents, for the community. Try to prevent the complication before it happens. So in the pediatric population, I think this is the one that we should emphasize more before the child is growing and entering the adulthood, in which the complications appear more severely.
I think he's made a very important point. We pediatric hematologists see the easier phase of sickle cell disease because they are young, they haven't had the disease for long, their organs haven't as yet suffered from damage. And so when we start disease-modifying therapy early, I believe that we're going to see a generation of patients who are healthier adults, who are healthier before they go to the adults. So you are absolutely right that early commencement of hydroxyurea therapy in childhood is going to have enormous benefits as they get older, and we may be able to have other interventions. Anyone of you wants to comment on that question?
I have a comment, as Dr. Abdullah said, also with the coming, gene therapy, still the hydroxyurea, I saw with pediatric hematology is the best. I'm from pediatric, genetic, and metabolic. But again, I think there is a big part for the awareness of the families and the quality of life, that if they maintain it with the best of that they can, with the compliance on medication, that will give them the chance that whatever gene therapy or whatever therapies is coming, their patient will be eligible. Number two, I find it that with this, high frequency we are seeing, the high carrier frequency we have, the continuous of the families that they are having, we have like second child, third child, in the same family they will have 2, 3, 4 patients. It's different than the family that they have only one affected patient, so they can take care more for this one affected. But if they have 3 and 4, the careness will be, divided and less. So again, one of the best is to concentrate on the prevention, and even if they are married, premarital, prenatal, PGD, whatever. So putting some effort, more effort in prenatal and antenatal, and make it available for those families is very important, as much as we are talking about the gene therapy and others. So we will not have the third and fourth.
Thank you. Great lectures. I've learned a lot, honestly, although I've been dedicating my life for sickle cell now for the past 20 years. Dr. Abdullah Zaid, you pressed really a button of pain that I have until now. My career showed me that when I practiced in Canada for 20 years, I've seen few patients, Afro-Canadian, who comes with a severe type. We manage them, and we manage them in an excellent way, and they're discharged home. The second step in my life took me to Khobar. I was working at Johns Hopkins Aramco in 2020, and there was always this that I consider a myth right now, that, those patients are with high hemoglobin F disease, Arab Indian haplotype, don't worry about them. You don't have them. I was saying the guidelines calls for hydroxyurea in all patients above 9 months of age, and everyone was saying, no, you don't have to, until I saw my first patient who hasn't been coming to the hospital at all, no much of clinical records on him, but he is an active patient at the hospital as well. No follow-ups, no hydroxyurea. TCD was not done because of this. And now, and then the patient came with vaso-occlusive crisis. I think it was osteomyelitis. In few days, multi-organ failure, and he died. We lost him. And I just stopped and I was shocked.
That is the left side, the corner
Exactly. It was honestly 5 days only that took him to death. And one of the slides that I presented previously are myths in sickle cell, and I think what I'm going to add is the myth about the Arab Indian haplotype. How can we change this myth as probably the only country who has two distinct phenotypes that are managed in a different way? We have to change this myth. But what's your advice, being the expert in the Eastern Province? Thank you.
Simply, I would say showing the data that we have, because these data are not outside there. And everybody, like shortly, a while ago, I was chatting about the Eastern Province patients, and they said, oh, that's with high hemoglobin F and the mild disease and so on. I said, no, that's really not true. That's not true, because we are not showing the data that we are facing. And this patient is a good example. They come within maybe a few days, if not a few hours. They just explode and you cannot do anything. Unfortunately, those cases are missed. And personally, I have two patients whom I'm scared of. Those patients who come so frequently because they think that, for us, I'm a physician, think that they have chronic pains, and all of a sudden they may come with really very severe painful crisis that we cannot catch them. And those patients who comes very rarely, and once they come, they do not give you any time to save them. But if we work on this, trying to get our cohort published and show the severity of their disease, this is the best way to convince people that we have really severe type, but we think it is a mild type. And what Prof. Sultan did is one of these efforts that we can show people that we have really, we have not a benign disease.
Do you think performing new generation sequencing on all patients would defeat this?
That's another one to go also. What I talk about the genetic and also the mutations that we have, probably it is also contributing to the severity of the disease.
I'm against sequencing the whole newborn, and this is illegal and can reveal a lot of things. We can do target sequencing, and I would love to do that, but unfortunately the current mindset won't push it. But target within the same hospital, if you have a case, if you have a carrier, most probably they will have a kid with the same disease. I would emphasize this is the proper screening. Screening starts by clinic, biochemical, then go to genetics. This is if we're going to talk about diagnostic. If you're going to talk about program should not be genetic at the first step. We did a lot of program around the world. We worked with different institutions. We never jump into genetic unless we are not qualified. But we are qualified enough to know there's different biochemical testing we can start with. There is false positive, false negative, but those can go, and this is require a good specialist in the lab who decide what to do for genetics. Not all the samples should go to genetics. We care about the finance of the government. We care about sustainability. But when a person say, we need to sequence all the population, especially the newborn, that's not ethical and not acceptable.
I thought the question was how to investigate. So that will be in a clinical research rather than a random investigation.
True.
Yeah, so in academic, we can do this and we can select whom our patient that we need to target.
Diagnostic, yes, but for most of the diagnostic, you would know what's the mutation or what the panel to be used or the gene.
No, I'm talking about the mutations, like in hematology and many other diseases.
Doctor, we see in the lab aggressive use of whole exome, whole genome, because doctor don't know this is a single point mutation. We can do a panel testing or we can do biochemical testing. But if there is a doubt with the diagnosis, they send it to whole genome, whole exome. There's doctor, they don't know how to distinguish between what test to be done, and they just put whole genome, whole exome. For me in the lab, I don't accept this.
Okay.
I only accept...
Forgive my ignorance. The study I showed that FLT1 mutation is a possible hemoglobin F inducer. How did they discover this?
This is research.
So this is what I'm talking about.
Yes,
I'm talking about
research is fine.
I'm not talking
But
about
what I'm saying, I'm talking about clinic, Doctor. Because we work in
no, I'm
labs.
not talking about the clinic. I'm talking about research. Dr. Hatun.
No, research is.
Yeah, this
It's
is
fine.
like I want the research.
So there are two parts here. One is the research part that we could explore and have evidence and then base. And there are programs that need to be implemented as soon as possible, at least to step up as a first step in the whole prevention. I would say prevention of death, prevention of complications, prevention of disease happening. So thank you.
We'll have the last question and then, or comment, and then we'll end this.
Thank you. Nice talk and nice discussion. I'm working here in Riyadh, and I have more than 700 sickler. It's both from Arab Indian, from Eastern Province, and from the South. I'm not saying Arab Indian is mild disease. I think they have significant disease. They deserve to start treatment from the beginning, including hydroxyurea. But from the population I saw, especially in pediatric, definitely those coming from the south having more severe disease than those from the Eastern Province. And I would like to hear comment of Dr. Hafid about this.
Dr. Fawaz, because you're a pediatrician. يعني this is more
أنا قلت
recognized
pediatrician وأعترف وأفتخر إني pediatrician.
Yes, ونحن فخورين بيك كمان.
Thank you, Dr. Fawaz. I'm working in Jizan. We have around 3,000 registered in our hospital in adult department, and we have less than that in pediatric, and still we are working to collect more registry. As you mentioned, our patients are very aggressive, and the literature mentioned and the research, they are from Benin genotype, and with, I think, all the complications mentioned in Dr. Zaid's lecture and all in the textbook are there in our patient, except leg ulcer is very rare in our patient. Other than that, stroke very common in our patient. More than 300 to 350 patients, they are affected by stroke. And thankfully, for BMT program with our college in King Faisal and National Guard, they are doing a lot of effort to help us in BMT for our patient.
So the message here is that sickle cell disease is a severe disease. In fact, I think it's inherited SLE. So if you're a clinician here, I want you to go with that idea. It's SLE, except that you are born with it. Right from the beginning, you are having endothelial damage going on. So that the thought about a mild disease that doesn't require treatment doesn't make sense. This is what we thought in the past. This should be thrown away. And I think clinicians should change their mind that you diagnose sickle cell disease, you treat. In fact, my dream is that before we get to in vivo gene therapy, and by the way, we are moving faster than we thought. I think in vivo gene therapy trials are going to begin in Africa within 2 years. We are getting there. No chemotherapy, no myeloablation, just take it from the shelf and provide in vivo. That will come, and I like your message. In the meantime, hydroxyurea is going to keep you well, preserve your organs, so that when we get to the era when these therapies are easily accessible with minimal toxicity, there'll be much more universal acceptance. But I'm hoping that we'll get other disease-modifying therapies, because sickle cell disease pathophysiology, having one drug alone is not sufficient. Perhaps we need multiple drugs targeting different pathways, just like we do for chemotherapy for cancer. And I think we may need to combine, because sometimes they are on hydroxyurea, and that's not sufficient. They are having end organ damage. But that's where the future goes, from genomics to prediction to early diagnosis and treatment. I think we'll get there. Thank you very much for this session.
We'll have a short break for 10 minutes, and please come at 6:25 to be able to release you home early. Thank you.
الجمل تحت ايه ده؟ لا الجمل الشنطة جوه عمال يعبوا بيه. ايه؟ يا غرام المصريين ها ها
هذا أيوة أوكي. السلام عليكم ورحمة الله وبركاته. Can we gather please? 2 minutes please to gather. If you can kindly call people from outside to come in. لولو ارسلي لي حق سو لويس سو المودريتور اللي معايا. يلا يلا سريع ها. باي باي. I really don't want to start the next unique lecture without a big gathering here. Because I promise you that you will hear something different. He's on the phone. والله قلت للناس كلهم حتى التيم حقي بس جاسر بليز نادي الناس يلا. Just a reminder, at the end of this session, we will show a QR code for evaluation of the day. I trust that everyone will do this. It will help us a lot in how to get better, improving, and how future summits would look like. So please scan the QR code once it's on the screen and fill the evaluation. We highly respect and appreciate this. Okay, so we'll start this session, which is the last one of the day, and hopefully it won't be long, but it will be exciting. I have my other moderator of the session is Professor Louis Su, who is a professor-in-chief of pediatric hematology oncology, the director of pediatric sickle cell at University of Illinois, Chicago. His training included MD, PhD from University of Rochester, pediatric residency at Yale, and pediatric hematology oncology at Children's Hospital of Philadelphia. He led pediatric sickle cell centers at Emory in Atlanta, St. Christopher's in Philadelphia, Children's National in DC, and now UIC. How did you manage all of this? Oh my God. He has devoted his career in sickle cell disease really for the past 3 decades as a physician, scientist, and an advocate. Early in his career, he worked on mouse models of sickle cell lung disease, the STOP, S-T-O-P, study of stroke prevention, and the multicenter study of bone marrow transplantation, Current research includes improving the delivery of sickle cell therapies using dissemination and implementation, science, community health workers, and global community engagement. I'm very happy and proud that you accepted our invitation. I'll present the first lecture. It's about diagnostics and point of care, imaging and point of care diagnostic. I'm very honored to present a great colleague, Dr. Abdulaziz Al-Hamoud, who I happened to know over the few years through working at Sahha Virtual Hospital. Dr. Al-Hamoud is a physician, executive, and a digital health expert based in Riyadh, Saudi Arabia. Currently serves as the CEO, advisor, and the Chief Innovation Officer at Sahha Virtual Hospital. In this role, he provided strategic guidance for national virtual care initiatives and played a pivotal role in introducing the National Digital Health Regulatory Sandbox. As the former Chief Medical Officer, Dr. Al-Hamoud led the design and launch of Sahha Virtual Hospital, earning international accreditation for virtual care. He practices emergency medicine at King Fahd Medical City and teaches at King Saud University School of Business. He has an executive educational background, including Masters of Science in Biomedical Informatics, an American Board Certificate in Clinical Informatics and Emergency Medicine. In addition of his consulting experience in Saudi Arabia and the US, he has also served as the G20 Health Working Groups and various other prestigious committees. He has an extensive educational background, including a Master of Science in Biomedical Informatics and the American Board, and I think I'm repeating same things. However, this is very impressive and long to be read at the end of the day, but I'm really honored to have Abdulaziz with us. Just something to mention, when they recommended his name to present, and I said, oh, Abdulaziz. Second day I met him and he said, your lecture is ready. Come to the stage.
Good evening. Hi. You guys hear me? Yeah? No? Okay. Hello? Yes, perfect. So I'm an ED doc, yeah. Standing in a podium is not going to happen. I'm just going to walk around, right? Thanks, Dr. Hatoun, for the introduction. And yeah, a lot of things that you mentioned, I'm not sure I've done it, but let's state the fact that I'm an ED doc. I still practice. And I like your intro, Dr. Sue, because I worked at the only children's hospital that you didn't in the US of that prestigious level, which is Texas Children. And fun fact about Dr. Hatoun, in 2020, when during COVID and things were hectic everywhere, and we figured that what we do in healthcare is not as good as what we expected. We worked together to build a virtual hospital, and the first clinic that we built at the National Virtual Hospital was the hematology clinic. In particular, we focused on benign hematology, sickle cell thalassemia, and where is Dr. Al-Qasim? I saw him a few minutes ago. Dr. Al-Qasim also was with us, and the lesson learned from that is if you have successful partners at your side, you're gonna make dreams happen. I'll try to give you an overview of why I'm here. I'm not a hematologist. I'm not a geneticist, but I'm still here, and I think it's relevant. And also, I know a lot of people in the here listening to us, and we've made a lot of friends throughout the couple of years. So we'll go over this quickly, and I will try to make it relevant. So, you know, the cost of living is going up, Bitcoins are also going up, and healthcare is also skyrocketing. No matter what we do, we're still trying to take advantage of the resources that we have. Life expectancies in Saudi is going to the right direction, but with still a lot of spendings. And I always tell my colleagues, do you want to spend 17% of your income in health care? Personally, I don't. And government should not do that too, unless they need to do better. We spoke about the life expectancy, but in reality, we're adding years, not necessarily adding quality. And we're not providing an equity in basic things, even clean water, right? So we need to do more. We need to take advantage of technology. I saw that there are quite a few international speakers, so I wanted to give you a quick background on why do you need to leverage technology? Why did we figure that moving faster and doubling down on technology is what we need to do? 32 million with robust technology, okay? We're ahead of a lot of global partners when it comes to infrastructure readiness. So what we did is we looked at our digital public infrastructure, and we decided to change that and making a digital public infrastructure for health. And always when you do something good, it comes back when you need it the most. When COVID came, it was easy for us to double down on the infrastructure, the resources, the decades of investment in healthcare and digital infrastructure, and it was readily available for us to use. The Global Digital Health Monitor is the WHO assessment tool for your digital health readiness, and Saudi was at level 5. So that put a lot of burden on us as physicians, as healthcare leaders, to take advantage of that. And when we started the virtual hospital as an example, it wasn't very hard for us to achieve, because you have the digital infrastructure ready, and you have a clear vision ready for you. If you come up with any products, any initiative that will align with Vision 2030, particularly in access or quality or prevention, Dr. Al-Isa, also we spoke about prevention a few minutes ago, then you're able to proceed. This is briefly the journey of digital transformation and the resources that we're using. I'll let you take pictures if you want. Perfect, yeah. Now, this is a quick video, I hope it works. From inside the virtual hospital. Can we have the voice? If not, that's fine. I could just share with you. So this is an MDT, multidisciplinary committee, and or virtual multidisciplinary committee processes, and we basically ensured that every service is leveraging MDTs. For hematology, for example, we have benign hematology MDT, and we've also created a pain management MDT, leveraging the resources that we have in-house, particularly in psychiatry, psychology, OT, and physiotherapy. This is an example from our endocrinology, but it applies to a lot of hematology activities. And this is the setup of our clinics. Perfect. So, when we looked at what can we do with that, we took the concept of telemedicine, and basically scratch that and make it virtual or digitally empowered or Now we're preaching for hybrid. So every service, every journey, every interaction has to go through a work flow that's partially virtual, partially digital, partially self-led, and partially, and rightfully so, in person, right? This is kind of the journey. We met with, me and Dr. Hatoun started to team up during the kind of virtual clinic concept, but quickly expanded to enhance the care provision by having a network of easily accessible expertise. So you don't only refer for a clinic, you refer for an asynchronous approach, you refer for MDT, you engage in management in tele-ICU, and you be part of how do we design the future. After building the virtual hospital setup, we figured that if you're an early adopter, then the next thing that you need to do is become innovation generator. And that was the time when I decided to hop in that journey and left the medical administration. So now we have a national regulatory sandbox for innovation incubation and ensure that the Saudi FDA processes takes are expedited, and a robust national R&D or National Digital Trial Center where we take advantage of existing registries, wearables, and whatnot. And you know, during the preparation for this lecture, I came across the hologram and the use of CBT and whatnot. But when I saw it just now here, I was like, wow, that's old news. But in reality, this is what we do, right? And with all the noise that comes from adding technologies, adding processes, enhancing your workflow, it's important to have, you know, pillars that you could always direct your processes to. We believe that virtual care, or starting from 2026, I will continue to say hybrid care rather than virtual, but we're going to improve efficiency, enhance patient experience, provider experience, also payer, they will like what you do, advancing clinical excellence, facilitate access. We're proud to say in Saudi, access to essential. So this is also a success journey because we improved access to essential care throughout the country, and then all of a sudden looked at that essential piece of care and empowered it by technology. You know, in the virtual hospital, for example, and this is one of many initiatives that Saudi has built, there are 1,500 primary care centers that they have an instant approach to talk to an expert. We call it Consult Plus, right? And we have a pool of 400 providers across all specialties that are accessible throughout that process. Because some of these consults are simple. For example, decision-making around you know, anemia processes and around iron deficiency anemia, whatnot. And those patients usually are just left behind. They're not sick enough to make it to the wall of fame, right? They cannot be referred and get accepted quickly. And they're not stable enough to stay with their PHC. Those are the departments that we have within the virtual hospital. And I want to focus on the fifth one, virtual medical support services, because we see there is a significant value here with a lot of subspecialties. In that group comes the virtual, the telepathology program. And do we have any pathologists in the room? I hope not, so I can make things up. Okay, good. So when it comes to pathology, it's still considered a very rare breed, particularly in lymphoma, lymph node pathologists and whatnot. I will not tell you the number, but it's less than, you know, a count of one hand, you know, less than 5 in Saudi when it comes to lymph node pathology within the Ministry of Health ecosystem. Ministry of Health covers like 5 to 50% at least, give or take, of the provision. And with the setup that we did in telepathology, we claimed that we will increase access to lymph node pathologists, for example, from less than 5 hospitals to all these 224 hospitals. And it is not a game of, by the way, I'm not monitoring the time, and I'm used to have long-winded lectures, so if I just let me know. Dr. Hutton, just wave to me. Yeah, so we did that with pathology. Perfect. And then we also took advantage of the registries that the Ministry of Health has, and there is an advantage of having central processes. So for example, at the Ministry of Health level, there are a lot of central processes, central purchases and whatnot. And we took advantage of that in building different registries. And now, by nature, you're already gonna have registries that are ready for action because they were built as part of the process. You know, you have to make it to the registry in order to get to some of the resources. This is in a nutshell how do we look at hematology. And I spoke with the organizing committee when we spoke about bedside and point of care diagnostics. And you know, when it comes to point of care diagnostics and imaging, what we do is basically, if you look at the clinical decision-making processes, we enhance that. 5 minutes? Okay. Yeah, we enhance that. And we ensure that there is a closed loop communication throughout the process, whether it's in PHC or in the ICU or whatnot. But I want you to focus on the MDT too. Yeah, that side. This is how we design our MDT process, and it's not rocket science. Those are a couple of examples. We don't have this up and running yet, but I worked with our colleagues at Redia to bring digital therapeutics as the upcoming priorities for research in the upcoming year. And I'm calling on our dear hematologists in the room to take up this challenge and do not let your sickle cell disease patients who are struggling with chronic disease, miss this opportunity. We're bringing digital therapeutics to the room. We don't want it to be focused only on psychiatry or you know, simple behavioral modification. We think that hematology, especially in Saudi sickle cell disease patients, need to have their fair share of that. And this is an example of how AI could support around the diagnostic and therapeutics. And a couple of reference to real-world impact of digital hematology clinic, way faster, high impact, high satisfaction, and growing confidence in technology. Another evidence in malignant hematology, clearly telemedicine and interactive ways are high, improved satisfaction and more effective. And this is just for my ER colleagues, the ability to move from ED to infusion centers for management of, and this is out of UCSD. I'm a big fan of this one. I'll try to implement it in Saudi. And thank you so much. Yeah.
And the continuous movement of the ER doctor is really evident. High energy. So I'm Louis Su. I'm a pediatric hematologist from Chicago. Thank you very much for the invitation to be here. And it's my pleasure to introduce the next speaker, Dr. Pablo Bartolucci. And so his bio is so long that I have to hold it up close here. So Dr. Bartolucci, MD, PhD, is professor of medicine, physician scientist, and also president of the Red Cell Disorders Network that spans 12 countries. And he's a very busy physician scientist who is recognized for his red cell disorders work, both as a clinician organizer, and also a researcher. He's been focusing on sickle cell disease, hemolysis, transfusion-related complications. He coordinates the French National Reference and Expertise Centers for sickle cell disease, thalassemia, and other rare red blood cell disorders. Over the past 5 years, he served as principal investigator for more than 30 clinical and translational studies spanning early phase clinical trials to large real-world cohort analysis. His research bridges fundamental mechanisms of hemoglobin, biology, oxidative stress, biomarkers, precision monitoring, exercise testing, and system-level clinical innovation. He's the president of RED, which is an international cooperative network spanning 12 countries dedicated to improving care research and training. He coordinates Cyclopédie, an integrated international digital platform that combines electronic medical records, multidisciplinary case discussions, and research infrastructure for rare diseases. He also has experience in design and implementing healthcare systems in diverse settings, including Cambodia and New Caledonia. He's developed field-tested models of coordinated care to translate clinical excellence into scalable healthcare systems. His vision is very forward-looking, structuring systems rather than just having isolated projects, and trying to connect high-income and resource-limited settings. So we look forward to his connections between scientific complexity and operational solutions. Dr. Bartolucci.
Well, thank you very much for the introduction. Very nice, thank you. And I'm very honored to be here with you for this Congress. And thank you for all the speakers before me, because my presentation will be easier because of the clarity of the speakers. Okay, so I will try to explain our approach on how to combine research, registries, and the clinical care. And it's quite tricky. So, as you know, in sickle cell, it's also the case for thalassemia and other red blood cell disorders, but especially for sickle cell, it's a systemic, complex disease requiring multidisciplinary care. You know that it's associated with a high mortality, and especially, for example, in France, half of the deaths are due to acute chest syndrome, and now half of the deaths are due to multi-organ damage with the aging of the patients. There are very fragmented patient pathways, and the unmet therapeutic needs is very high in the disease. So how to better investigate and know how to better improve the care of the patients, it's based on a conception of hyperphenotype cohorts of patients in order to better understand what are the risks, what are the predictions, and what are the pathophysiology of these complications. So taking the general population of sickle cell patients, we have to go to targeted populations with hyperphenotype multimodal models, including clinical, radiological, biological, and also genetical data, trying to explain this paradox that has been told many times before, which is that sickle cell is due to a single gene mutation, and despite this, it's a very complicated and very with a high variability, inter-variability, but also intra-variability during the long life. We talked about artificial intelligence, but if we don't have the good data, we don't have the models. And that's why actually the idea is not only focusing on the disease, but focusing on each person having the disease. For this, we know now, and it has been said, that there are different biomarkers, and we talked a lot about the percentage of HbF, and it's correct that the percentage of HbF alone cannot explain the severity of the disease. Despite this, we all know that it's a huge therapeutic target with the Casgevy, with other gene therapy strategies, but also with the next generation drugs targeting the increase of the HbF. So why is there this paradox of the HbF? It's mainly due to the fact that we don't have the tools to better understand what is the distribution of the HbF and the HbS by cell. And so we developed a single cell test, as we also talked about the hemolytic phenotype, and we didn't have the good tools to investigate this, so we had to invent a tool which make us able to measure the plasma heme excess. And with this, we have a better approach with the single cell HbF and HbS to have the distribution and then understand what are the red cells really protected against the disease, but also the red cells that are not protecting at all. And then cell by cell, we can finally have a better picture of what is appearing. Otherwise, we just have the mean with the percentage, which is just an approximation. On the other hand, and it's a paper under review, the heme excess appears to be the best biomarker associated with organ damage, and for the mortality at more than 10 years, with a big cohort of patients we follow more than 10 years, we could see that this biomarker is much better than the LDH or the percentage of retics, with a p-value which is 0.003, whereas there is just a trend with the LDH. And this is important because it's in clear relationship with the pathophysiology. We know that the heme triggers the TLR4. It's also an activator of the complement pathway and also of the thrombosis. Now let's talk about the registers. We need to have a very good picture for each complication to better understand what we are doing, what we have to screen, and how to follow the patients. That's something that we began more than 10 years ago, trying to have cohorts of patients with a hyperphenotype. So each cohort has a patient pathway and also multidisciplinary meetings. And with the Drepacker cohort, trying to better understand the cardiac involvement, myocardial fibrosis, and arrhythmia risk. The Étendard cohort for pulmonary hypertension. The GenMod, which is for the kidney damage, but also we published a paper on the clonal myelopoid clones. And PCDREP for the brain with stroke prevention, but also the exploration of cerebral vascular pathways. We have others, but these are, I think, the most important examples that about what we are doing. And they lead to new insights and change our way to manage the patients. I will just take some examples. For the heart, we discovered that 20% of the patients experiencing a stroke were due to cardiac embolism. And these patients were treated by erythrophoresis, which was not the correct treatment. So this make a change in the way to treat the patients. With non-supervised analysis, we discovered that there were some clusters that we completely ignore, that were very severe and that we have to target. With the PC-Lab cohort, we better understand how to deal with the brain perfusion, which is very complicated to analyze in Moya patients. And this is thanks to a platform, which name is Cyclopedy, which has, I would say that it's like an innovative concept, because when we began, everyone said you cannot have a register and a patient file. And we try to demonstrate that it's not the case. So why it's complicated? Because the jobs are different. You have researchers on one way, assistant clinical researchers entering the data, and on the other side, you have the clinical practitioners. The point is that you need a high manpower if you just do the registers. And these registers, they don't deserve the patients. So if you connect both, and it's quite tricky at the beginning, you can have a perfect follow-up, and you can benefit the patient from the research directly at the single level. And that's what we did, and that's why finally we could develop and spread this model to actually 39 hospitals and more than 7,000 patients quite fast in 1.5 years because of this relationship. The next step is the patient. We need that the patient can control the disease, and the app that we are developing will make the patient able to have a QR code whenever and where, even in all the world, to just show to the physician what is the resume of his disease. But he will be also able to provide some data as the ePro, as quality of life, as the authorizations to perform research. And the last part is Cyclopedy Link, which make us able to have a coordinator platform to have the same patient file among the entire system. So in France, each hospital has its own patient file, and with this platform we can connect and have the follow-up of the same patient even in different hospitals. So this is just the different tabs of Cyclopedy. And now, what's about the prediction? As you know, one of the challenges of sickle cell is unpredictability and severity. The VOC is still the first cause of death, and we cannot predict when the patient will have a very severe VOC. The acute chest syndrome appears in 20% of the VOCs, and it's at the third day of the hospitalization in almost 3 studies. So could we prevent, could we know who are the patients that will develop this acute chest syndrome since the arrival to the emergency department? And the answer is yes. Almost we can say who are the patients who will not develop the acute chest syndrome. So thanks to a study in our hospital, we had a very good predictive negative value that we replicated in 5 countries, including 2 in Africa, with excellent score also in Africa. And so we build a new pathway leading us to follow the patients with a telemedicine at home for those patients at low risk of acute chest syndrome. And we treat 200 patients by this way with a very good results, and the patients were very happy to have this possibility to stay at home. On the other side, could we predict in the future who are the patients who will have a GFR decline? So we conduct a study with Center Saraf in Chicago based on more than 10 years of a follow-up with the GenMod cohort and with his cohort. And so that finally, if you have the SER at baseline, according to this SER, you have a very good insight on the GFR decline, which is very simple and very similar to diabetes, but it was not clearly shown in a prospective way, and also the role of tobacco. So people, the sickle cell patients smoking have a higher GFR decline. Now, 15 to 30% of the death are sudden death in sickle cell. And when we don't know what is the sudden death, we say it's pulmonary embolism. So that's what I heard every time. So finally, with all this data, we thought about the fact that perhaps it was not thromboembolism, pulmonary embolism. And we look at in the cohort, Drepacker, and did systematically a Holter ECG. And we found 41% of these selected patients having severe ventricular arrhythmia, and some of them very, very severe. So we thought that probably a part of the sudden death, if it's not the majority, could be due to this ventricular arrhythmia that were completely undiagnosed. And so now, thanks to finally the best marker, the best predictor of ventricular arrhythmia, which is the longitudinal strain that we didn't look at before. Now in the clinical current care, we look at the strain, and when the strain is lower than 17, then we perform Holter ECG every year. And providing beta blockers, we reverse this risk for many of these patients. Now, trying to go further, we know who are the patients at risk to have an acute chest syndrome at the arrival at the emergency department, but the point is, could we even know who are the patients who will develop a VOC in the next year? So with Innovem, which is the company I co-founded and also which developed the biomarkers I showed you, we have now a score, which name is VOC Predict, with a very good ROC curve, predicting with a simple biomarkers who are the patients who will develop a VOC in the next year. So now, and we also want to better improve a predictive risk factor algorithm for organ damage. So now there is the project Evolve, which will be personal medicine based on this algorithm. So if we know that the patient will develop a VOC, we don't have to wait to increase our therapeutic strategy or to prevent the VOC or to put all the efforts. We cannot do it for all the patients. It's impossible in terms of manpower. But for 20% of the patients, we can have this very, I would say, rigorous strategy. And this includes also the explanations to the patient of the home care models, or even how we have a program to keep the children for the woman alone with the children when they are hospitalized. So this will be a study, a randomized study, to prove that when we have the algorithm, we do better than without the algorithm. Now, this is in France, but indeed the RED network includes 12 countries, and we are very committed in Africa, and especially in the second country in the world with sickle cell disease, which is Congo-Kinshasa. And in Congo-Kinshasa, we try to improve and set up a new way to coordinate the healthcare. This is based on our experience that we had last year with a terrible cyclone Chido in Mayotte, near Comores, which was devastating. And they had no medical care system for a few weeks. And thanks to Cyclopédie, at 8,000 kilometers, we could have a hotline and call the parents of the children one by one, and in 3 weeks we secure all the children with sickle cell disease with 10 hospitalization in real-time coordination with the physicians in the island. So, of course, we need new tools, not only to train, because I participate to train physicians in Africa for more than 10 years, but we have to train also all the caregivers, and especially in the primary care system, which is, in my opinion, not enough used in Africa. And so to better disseminate this, we want to integrate the MOOC inside the platform, and we also have the project to combine all these skills in a unique place in my university. So all together, we finally build a consortium, including the research, clinical management, and training education, to trying to do better than we are doing actually. So thanks. So this is my clinical and research team, and of course there are many other collaborators, and I thank you for your attention. Thank you.
Okay. Wow, so many things going on. While our host comes up, I just want to say, so I'm a clinician and also researcher, and I have so many questions.
Probably before we start the panel, we will do one more lecture, and then we could sit all of us and discuss. Okay. Because I know that the next lecture is not an inherited blood disorder, but having the expert with us who are part of this is very important. I stood in particular here to thank, first of all, Dr. Tariq Oueda for being with us. Dr. Tariq is a great colleague, honestly, and I don't want to say that he's older than me, but he's a very close friend of my uncle who's an oncologist. And this is the way that I got Dr. Oueda introduced to me. But Professor Oueda is currently the director and a consultant hematopathologist in the blood bank and transfusion services of pathology and laboratory medicine division at King Faisal Specialist Hospital and Research Center, Riyadh, since 2001. He is also a professor of hematology and transfusion medicine at Al Faisal University in Riyadh. A consultant hematopathologist. Dr. Oueda's special interest focus on thrombosis and hemostasis, as well as transfusion medicine. He is heavily involved in diagnosis and management of various thrombotic and bleeding disorder. He was the deputy director of blood bank since 2005, deputy director of stem cell and cord blood bank since 2007, and a member of the National Committee for Blood Banking for a few years. Dr. Oueda's main research interest is antiphospholipid syndrome, pathogenesis, with investigation about new diagnostic and therapeutic modalities in cancer related to thrombosis, with 22 approved research projects. He published more than 91 articles in a peer-reviewed journal and 36 abstracts. And all of the dates that you provided in your bio just speaks to what I said, so it's not my fault anymore. So Dr. Oueda will be moderating the next session.
Assalamu alaikum. Good evening, everybody. Thank you, Dr. Hatun, dear friend and colleague, and congratulations for your fourth and continue educational activity in the country, leading and promoting education, particularly in non-malignant and what being called sometimes benign or general hematology. It's my pleasure to be here tonight and it's a great pleasure to see friends and colleagues who are gathering tonight to share experience and exchange knowledge, which is an important thing that we miss these days, especially in some areas where the experience varies between, even within the same country, you can see variable experience coming from west to east to central and south. I've been asked to introduce a dear colleague, Dr. Sheikh Al-Utaibi, who is for a long time been with us in King Faisal. Sheikh has recently been appointed as the head of general hematology. General hematology is referred to non-malignant hematology or benign or classical hematology. A lot of names came to represent the hematology part, which used to be unrecognized or because of the malignant being dominant, but fortunately now I can see that it gains a lot of concerns, and people are recognize the general hematology, which includes a variable number of disorders, and the prevalence of these disorders much commoner than the disorders of malignancy, which doesn't mean that it is inferior, but I think with the high prevalence it needs to get more attention. I will not take much time. I would like to welcome Dr. Sheikha to present an interesting subject, which is PNH, paroxysmal nocturnal hemoglobinuria. And that's a disease, I think, she will give us a lot of information about the diagnosis and management, and I'm sure the discussion will be of great interest. Dr. Sheikha.
Thank you, Dr. Aweda, for the introduction. It's a pleasure to be here since it's the last lecture. Without further delay, I will move to the outlines of my presentation, but I think I need help. Okay, so the outlines of my presentation will be about the overview of the pathogenesis of PNH, PNH therapeutic options. We'll talk about the therapeutic landscape of PNH, moving to the identifying PNH patient, PNH anaplastic anemia, PNH clones monitoring, and treatment in aplastic anemia patient. So to start with, we'll talk about the pathogenesis. So normal RBC are protected from the hemolysis by the presence of the CD55 and CD59 through a protein anchor. So in case of PNH, these protein anchors are missing, so these RBCs are susceptible to hemolysis through the membrane attack complex, causing the intravascular hemolysis, in addition to the C3 opsonization resulting in extravascular hemolysis. So PNH is a rare, life-threatening clonal hematopoietic stem cell disorder caused by uncontrolled complement activity mediated by alternative pathway. PNH is caused by acquired somatic mutation in the PEGA gene and clonal expansion of these mutated cells. This leads to RBC deficient and GBI anchored protein, including complement regulator CD55-59, which results in intravascular hemolysis due to uncontrolled complement activity and membrane attack complex formation, forming pores on the RBC surface, resulting in intravascular hemolysis. RBCs are consequently vulnerable to dysregulated complement-mediated hemolysis. So as a result of this, patient with PNH will be susceptible to having intra and extravascular hemolysis, thrombosis, and the mechanism of thrombosis in this case will be mediated by the C5 activation leading to complement cascade, coagulation cascades activation. In addition to that, bone marrow failure. Bone marrow failure is associated but not as a result of PNH, and we'll talk about this at the end of the presentation. Now, historically, the survival of patients with PNH used to be inferior to age and gender matched control, and the median survival used to be around 10 years after diagnosis. But with the introduction of the eculizumab, we noticed a remarkable improvement in the survival of this group of patients. It became almost comparable to the age and gender matched group. Now, moving to the PNH treatment landscape, started by the approval of the C5 complement inhibitor, eculizumab, in 2007. That was followed by the ravulizumab, which is again a C5 complement inhibitor in 2018-2019, followed by the pixiptacoplan, which is a proximal complement inhibitor given and subcut injection in 2021. Then the danicopan and the I forgot the last one, iptacopan in 2024-2025. Iptacopan is the only oral medication available for patients with PNH. So talking about the C5 inhibitor for proximal nocturnal hemoglobinuria, so the response category for patients who are being treated with ravulizumab or eculizumab relies mainly on the hemoglobin level and the transfusion requirement. But additional long-term data have confirmed that despite the overall sustained efficacy and improved survival under eculizumab treatment, hematological benefit from eculizumab can be variable. Thus, in addition to transfusion requirement, hemoglobin normalization appears to be a discrete endpoint which can be used to characterize hematological response. As a result of this, the response criteria had been modified and categorized into 6 categories based on the red blood cell transfusion, the hemoglobin level, LDH, and the absolute reticulocytes count. So patient will be labeled as patient will be categorized under a complete response if he is if he stopped requiring transfusion, hemoglobin is 12 and above, with LD level 1.5 lower than the upper limit of normal, and reticulocytes count less than 150,000, and so on. So there are some limiting factors. We know that C5 inhibitors had contributed to the PNH survival and had impacted the outcome of patients with PNH, yet the outcome is limited by the following. So patients who are being treated with C5 inhibitors are noticed to have ongoing anemia. This anemia can be caused by the emergence of C3-mediated extravascular hemolysis, residual intravascular hemolysis, in addition to bone marrow dysfunction. So as you can see here, the C5 inhibitors, it inhibits the C5 at the bottom of the complement cascade, making C3 free and available for the RBC. So the RBC will be opsonized by the C3, predisposing to extravascular hemolysis as a result of the C3 opsonization. So the emergence of extravascular hemolysis is experienced by 25 to 50% of patients treated with C5 inhibitor. In this study, when they studied the extravascular hemolysis rate in patients treated with eculizumab, it was found that optimal hematological response, defined as transfusion independence and hemoglobin level with more than 11%, was only found in 37%. In 12% and 7% of the patient, so total of around 20%, continued to have transfusion requirement. So they tried to study the correlation between the positive C3 RBC with the response. So they found that optimal responder patients tend to have lower C3 positive RBC, while patients who are having partial response had higher C3 positive RBC. Another contributing factor to the persistent anemia in patients who are treated with the C5 inhibitors are the intravascular hemolysis, and this is because of the residual intravascular, this is because of the incomplete C5 inhibition. So incomplete C5 inhibition can result in breakthrough hemolysis that can be pharmacodynamic or pharmacokinetic. We'll talk about each one of them. So in pharmacokinetic breakthrough hemolysis or intravascular hemolysis, it is characterized by the frequent reappearance of hemolysis in few hours or days before the next administration of the eculizumab without any obvious trigger or complement activating condition, described in about 10 to 15% of PNH patients on eculizumab. The pharmacodynamic breakthrough intravascular hemolysis is caused by massive complement activation exceeding the inhibitory ability of the eculizumab that is independent of its plasma level. It is associated with infectious episodes or other clinical conditions that trigger complement activation. And to differentiate between pharmacokinetics and pharmacodynamics breakthrough hemolysis, you can look at the time frame. So pharmacokinetic breakthrough hemolysis, it happens 7 to 10 days, more than 7 to 10 days from the previous dosing. Pharmacodynamics happens before the overwhelming complement activation, so it has nothing to do with the timing of the previous complement inhibitor. The breakthrough hemolysis, it can be clinical or subclinical depending on the magnitude of the drop in the hemoglobin. Now, another important aspect of PNH is the fatigue. Overall, 75 to 89% of patients with PNH treated with C5 inhibitor experience fatigue, and is recognized as the most disabling PNH symptoms. Patients with hemoglobin less than 10 reported significant higher frequencies of fatigue compared to patients with hemoglobin level of more than 10.5. So as you can see here, in the eculizumab treated patient, 89% of them continued to have fatigue despite becoming transfusion independent. And for patients with ravulizumab, 75% of them continued to experience fatigue despite being transfusion independent. Now, the other important aspect of ravulizumab or eculizumab, the C5 inhibitors, they're not convenient to the patient nor to the health system because of the route of administration and the time it needs to administer. So for eculizumab, patient needs to come to the hospital every 2 weeks, and for the ravulizumab, patient needs to come to the hospital every 8 weeks. So it's time consuming and it's non-convenient for the patient. So to conclude, talking about the C5 inhibitor represent a major turning point in PNH management and are associated with improved survival and control intravascular hemolysis. Despite therapy, 50 to 82% of patients do not achieve normal hemoglobin levels. Persistent anemia remains a common, primarily driven by C3-mediated extravascular hemolysis. 23 to 39% of patients remain transfusion dependent despite ongoing C5 inhibition. Fatigue persists up to 75 to 89% of patients, remaining the most disabling symptom. Treatment burden is significant due to frequent intravenous infusion and the prolonged administration time. These limitations highlight the ongoing unmet clinical needs and support the development of more comprehensive complement inhibition strategies to improve hematological outcome and quality of life. Now, moving now to the proximal complement inhibitor, starting with the pegcetacoplan that was approved in 2021. So pegcetacoplan target C3 to control both intravascular and extravascular hemolysis. So it starts at the earliest stage of the complement cascade. Pegcetacoplan is administered as twice weekly subcutaneous injection. So the PEGASUS trial were designed to compare the outcome of pegcetacoplan compared to the C5 inhibitor, and you can see a huge difference when it comes to the median hemoglobin response in patients treated with pegcetacoplan. As you can see here, the median hemoglobin is around 11 in patients treated with pegcetacoplan, where it's around 8 in patients treated with C5 inhibitor. In the 4-week run-in period, you can see that patients, because they were treated with both pegcetacoplan and eculizumab, you can see a significant improvement in hemoglobin, but it dropped when they stopped taking pegcetacoplan. They were switched to eculizumab. Fatigue score was also better in patients treated with pegcetacoplan, and this is correlated with the median hemoglobin level. So a total of 35 patients, which is 85% receiving pegcetacoplan, as compared with 6 patients, which is 15% in patients receiving eculizumab, no longer required transfusion. Functional assessment of chronic illness, therapy fatigue scores improved from baseline in the pegcetacoplan group. Moving now to the danicopan. Danicopan, it works again by inhibiting factor D, so it's a proximal factor inhibitor. It blocks the alternative pathway amplification loop, consequently downstream the effect in the terminal pathway, as 80% of activity that progress through C5 convertase due to the amplification loop. So the result of the study when patients were treated with add-on danicopan, you can see here. So the hemoglobin had improved after patients were switched from the C5 inhibitors to danicopan, and the hemoglobin level had maintained between 11 to 12. Again, this is the absolute reticulocytes count. You can see a significant drop after starting patient on danicopan in addition to the C5 inhibitor. Moving to the iptacopan, which is an oral factor B inhibitor, which is first in class, administered twice daily, providing proximal complement inhibition and control both intra and extravascular hemolysis. And this is because, as you can see here, it blocks both C3, which mediates the extravascular hemolysis, in addition to C5, which mediates the intravascular hemolysis. Again, so the APPLY PNH study, which compared the results of patient treated with iptacopan and complement 5 inhibitors, you can see a difference in the estimated in the hemoglobin level. So the increase from baseline in hemoglobin of 2 grams per deciliter between day 126 and day 168 there was a huge difference, so 82% in the iptacopan group compared to 2% in the C5 inhibitor group. Again, the mean hemoglobin level was higher in patient treated with the proximal inhibitor, which is iptacopan, compared to patient treated with C5 inhibitor. So moving to the second part of my presentation, which is identifying patient with PNH. So we know that PNH is associated with unspecific symptoms, yet is associated with life-threatening consequences. Therefore, catch mnemonic was proposed to help clinicians to identify those patients and protect them from these life-threatening consequences. So C stands for unexplained cytopenia. So with any of the following, any subtypes with evidence of hemolysis, refractory iron deficiency, non-responsive to therapy or thrombosis. A for aplastic anemia or MDS. T for unexplained thrombosis. C for Combs negative hemolytic anemia, and H for hemoglobinuria. So moving to the last part of my presentation, which is aplastic anemia and PNH. So the GBI act as a membrane anchor for many cells. In acquired aplastic anemia, immune-mediated T-cell attacks target normal hematopoietic stem cells, while beta mutated PNH stem cells lacking the GBI anchor immune ligand escape cytotoxic killing cells, allowing their preferent survival and clonal expansion. So the detection of clones more than 1% in patients with acquired aplastic anemia is considered to exclude patients from having inherited bone marrow failure syndrome and have been validated in clinical and research setting. The presence of PNH type cells in patients with bone marrow failure may predict the development of hemolytic PNH. Indeed, 10 to 25% of all patients with aplastic anemia progress to hemolytic PNH after successful IST. So to look at the dynamic of PNH clones in patients with aplastic anemia, this study was conducted and 75 patients with aplastic anemia, minority of them had MDS, were followed over around 7 years. Majority of them, like 50+%, continued to have persistent PNH, so the clone continued to be stable, not associated with hemolytic anemia and not expanding. Around 11% developed classic PNH. Around 17% had expanded their clones without developing like a clinically evident PNH. Around 20% had PNH clone disappeared. So what's the impact of PNH clones on patient with aplastic anemia or MDS? So the impact of PNH clones on this group of patients is positive. It predicts better response to immunosuppressive treatment, better response to transplant, less disease progression, and associated with a lower leukemic evolution or clonal evolution. Now, is patient with aplastic anemia and PNH prone to develop thrombosis? Yes, and it's independent of the PNH clone. So 10-year cumulative incidence of thrombosis was not significantly different between PNH and aplastic anemia with PNH. Now, how to monitor patients with PNH clones who are diagnosed to have aplastic anemia or PNH? There are different recommendations. The British recommendation, for example, from the PSH, recommend to follow patient by doing PNH screen if they are having persistently positive PNH every 3 months for the first 2 years. Stop doing it or minimize it if the PNH clones started to decrease. Most of the other recommendation recommend to continue monitoring it every 6 months for 2 years. In resources limited countries, they recommended to follow it every 1 year. Now, how to manage patient with the PNH and aplastic anemia? It depends on the predominant picture. So if a patient is having hemolytic anemia with the PNH, you treat with complement inhibitor. If the patient is having PNH with a picture of aplastic anemia, you treat as such. For non-severe aplastic anemia, you treat according to the severity. For the severe or very severe, you treat with transplant if they are younger than age of 40, and so on. So to conclude, PNH is a rare life-threatening clonal stem cell disorder driven by uncontrolled complement activation resulting in hemolysis, bone marrow failure, and thrombosis. C5 inhibitor have transformed outcomes by effectively controlling intravascular hemolysis and improving survival. However, many patients continue to experience persistent anemia, fatigue, transfusion dependence, and treatment burden. Ongoing complement activity upstream of C5 explain key unmet needs, particularly C3-mediated extravascular hemolysis and breakthrough hemolysis. Novel proximal complement inhibitors add-on strategies are addressing these gaps with encouraging of improvement in the hemoglobin level, transfusion independence, and quality of life. Early recognition of PNH, careful monitoring of clones, and individualized therapeutic strategies are essential. The evolving complement landscape offers the potential for more comprehensive disease control and better long-term outcomes for patients with PNH. Thank you very much for listening. I'll be happy to answer any question.
Thank you, Dr. Sheikha, for excellent overview of PNH. I'm sure that it will generate a good number of questions. I'd like to have... Okay, good. So you lead it.
Can I have the speakers of the first 2 sessions, please, on stage for the panel?
evaluation قصدك؟
لا السلايد حقت الريجستري اللي بعت لك هي.
هي دي عايزاها النهارده؟
ايوه.
طب حاضر.
هذه اللي this is what I referred to. بعت لك هي على الواتساب.
هبعتها له حالا. انا فاكرها بكره والله.
Great talk. Great talks, great discussion. There are multiple topics that we've tackled this evening, so we're happy to take questions. I know Dr. Su has some for Pablo.
Thank you so much. So I think one of the themes that was coming through with the registries and with virtual hospital is just how much technology can do. And yet at the same time, I have patients who will willingly sign up for any convenience store, database, they'll sign up for all kinds of other things commercially, but when they come to a medical thing, they get frozen and they say, this is gonna get hacked, this is gonna get leaked. How do you deal with that when you're going intrinsically into a very big data situation? Is that a problem?
I'm not sure to have correctly understood the question.
Patient trust in
yeah.
a big electronic system.
Yeah, it's a complicated approach, and it's very different from one patient to another and from one culture to another. That's why we recruit a philosophist specialized in artificial intelligence to have this kind of approach in Africa, for example, to better understand what is the feeling about, on the artificial intelligence, or even in the digital tools from these persons, and also in France, and trying to not to have an app that will be just provided to the patients, but to make the patients finally deciding what is the app to have. So for the moment, the only thing we did for the app is the QR code, because all the patients want to have their own information all around the world. I have some patients going to Japan, to Seoul, and they need to say, I'm not transfusible, or I had a moya, etc. So this is the first step. But for the next step, we really want to have this approach with the patients.
Yeah, maybe I comment briefly on that, because if you want to take advantage of technology, then you will need to have massive outreach. And research by nature is sophisticated, and at least we want to make it look sophisticated. And the terms, if you read it easily, it's not, it's basically in making patients feel that they're going to sign off their rights. So, and maybe we spoke with this, Dr. Hatoun, in the ministry level, we're building a national digital clinical trial center where we bring everybody to talk about that. And in our first national committee, almost half of the time went into what is the right approach if you want to basically democratize access to research. Make access to clinical trial part of the natural process within the, especially when patients with chronic disease, especially when you have someone with chronic disease, how do you make them have that mindset of going through the clinical trial participation easily? It's not always an investigational drug. Sometimes it's access to data. Sometimes it's being part of a cohort. We need to do more in order to make that more accessible, yeah.
Maybe we can switch the gear to the other disease. Yeah. Hafid?
Thank you, all speaker, and my question to Dr. Sheikha from the clinical side regarding the PNH. From this presence of multiple medication now evolving in PNH, and between two brackets, it's very expensive medication. How we can tailor the options for our patient in presence of this multiple option, and unfortunately is not available in all the center.
I think 2 points to consider is the long-term data. So eculizumab is an old drug, so the safety profile is better compared to the new drug, not because they're unsafe, but because they're new. And the other thing, cost effectiveness has to be considered always, because you want to treat all patients equally. So I think this will come through collaboration with the sponsoring drug companies, but for me, I would go with the old generation like C5 inhibitors, and then with the more data, I might switch to the proximal inhibitors, depending on the profile of the patient also.
Maybe, yeah, please.
Thank you very much. Dr. Abdullah Meshi, a blood transfusion consultant from Jazan. My question to Dr. Bello regarding the connection between research and the clinical setting in sickle cell anemia in particular, for example. How accurate you would consider a predictor, whether it's a biomarker or a clinical outcome, to be used as a diagnostic, or to use it for clinical management, given that we know that research could not be as accurate as possible. We need more sample size. We need to generalize this to different population. So how easy it's really to make sure that I got this in research and now I can use it in the clinical decision?
Yeah, it's a very good question. Thank you. I would say that it implicates a real connection between researcher or the research field and the clinicians, because finally the good question comes from the patient, and so we have to adapt the way of thinking on the research to answer the question. If we take just, for example, if we take the vaso-occlusive crisis trials, they are all negative. And if you look at the outcome cannot be good from one country to another. It's very difficult, because what is the end of a VOC? Is it the end of the opioid use? Is it the end of the pain? Is it the end of the inflammation? No one knows. If you take the problem on the other side and you think about finally what will kill the patient, and it's the acute chest syndrome, which is sometimes with multi-organ failure, but the acute chest syndrome is central. So if you said, I'm trying to finally adapt my clinical trials not to decrease the length stay or the hospitalization, but to prevent the acute chest syndrome, this means that you need to have a predictor of the acute chest syndrome. And then you can have a good protocol, double arm, where in one arm you are looking the incidence of the acute chest syndrome, and on the other arm you have the standard of care. So it's just an example, but I think it's really important to have the good outcomes, the good, I would say, way of thinking on the patients, and not finally adapt our methods to bad outcomes.
Okay, I would like just to ask a question that complementary to what Sheikha had presented about PNH. I think Sheikha had raised the concerns about PNH, but since it's a rare disease, I would like to know how many of the audience had seen or suspected PNH and had the capability to diagnose and manage. Is it something everybody entertain, or it's quite rare disease that necessitate to be allocated to specific centers? And that's not new, by the way. Many countries in the world, including UK and US, they have centers to to treat and diagnose. So is it something everybody agree that it's rare, or it's not looked at, overlooked or underlooked, if you can say, in practice?
So I think it's underlooked disease because it's rare, yet it's associated with life-threatening consequences. That's why they came up with the catch mnemonics in order to help clinicians to identify this group of patients. So I think what we have to do is to increase and raise awareness of primary physician, and not in the tertiary centers like in our hospital, but in other centers, because the first contact with the patient will come with them. So, so I think it's underdiagnosed rather than.
I think I support that. It depends really on the clinical experience of a hematologist. But from my experience, I do realize that rarely of a time when we see a patient, we put first on the differential diagnosis PNH. It always comes the second or the last, or after trying some sort of a therapeutic that didn't work, then we scratch our heads and say, hey, maybe it's PNH. So I totally agree that it is under-recognized. And I think for this simple reason, because the summit is inherited blood disorder, but it's rare diseases, we're bringing diseases that had myths for a long time, that we need to change the vision of the community and the culture about them, and PNH is one of them. Isaac?
Yes, I just want to comment on the question that that honorable doctor asked. I mean, I think in oncology, stratification based on risk factors has become standard of care. That not all patients who present with acute leukemia are the same. You use certain factors to determine how you treat them. And I think what he's trying to do with the sickle cell disease is similar. That you want to predict who is more likely with vaso-occlusive pain to go into acute chest syndrome. It may not be 100% accurate, but it's better than your clinical judgment. And I think that is why this is actually something we need to embrace, because our clinical judgment is not good enough to be able to predict who is going to be a bad actor and who is going to be a good actor. And this has been the practice. So medicine is going to become more precise, and I think this is all a direction towards precision medicine, that no two patients are the same. You have predictive factors that tells you who is going to be different from the other, so that you can provide appropriate treatment. So I think it's time for the sickle cell community to embrace this whole approach of being smarter in predicting patients who are more likely to go into trouble, and then we can intervene much earlier. So I just wanted to add a comment to that.
It's just fascinating how we could switch between diseases, but I think the message we're passing here, that there are diseases that have been called benign for a long time, they're not actually benign, and PNH is one of them. Sickle cell and thalassemia and the other diseases we're discussing is. I think I'm honored since we have all the experts in the room, and since the great presentation that Pablo gave us, to show to you guys the latest dashboard from the Ministry of Health Inherited Blood Disorder Registry. So this is, we've completed, alhamdulillah, phase 2. The registry had evolved through multiple steps. I remember in 2019, before starting this, just structuring it, I had a presentation, and I was shaking a bit shaky to stand on the stage and say that I think we have 120,000 patients in the country. And now completing phase 2, we've recognized more than 100,000 patients with inherited blood disorder, namely sickle cell, thalassemia, hemophilia, and rare bleeding disorders. 78,000 of them are sickle cell. This is to recognize as well that phase 2 just included MOH sites, and it's a call for action now because we're moving to phase 3. And the objective of phase 3 is to start including non-MOH sites. So I do invite colleagues in other non-MOH sectors to join this national move. We've creating research out of this. We've used the registry as an electronic medical record platform, which I like about your presentation, where you tied up research with the clinical care. So that's the main hub now in MOH and moving forward to align with the Vision 2030. So if you have any questions or comments, please feel free.
Thank you so much. This is Arwa Riyami from Sultan Qaboos University Hospital, University Medical City in Oman. I just have a comment in regards to PNH diagnosis and management in Oman. We do have centralized testing as well as therapy for patients with PNH in the country. And I think it's not only that can be underdiagnosed and under-referred to the specialist in different countries, but also we really require good pathologists and hematopathologists and great sensitive assays to be able to detect PNH, especially if it is associated with underlying bone marrow failure disorders. With regards to the great presentation that was presented by Dr. Pablo, I was very interested to learn about this new technology that you have in France to link different registries as well as databases for patients with sickle cell disease. And the reason why is because in many countries we do suffer from fragmented healthcare systems for patients. And for blood bankers, it's a nightmare for us to manage patients if we don't know their baseline phenotype, their underlying alloantibodies, and therefore to determine the type of blood that we give. So I was interested to know whether if that sort of data, the laboratory data, is included in the Spledia link, and if patients as well as doctors can have access to this important transfusion data that can guide transfusion decisions for this group of patients. And if so, if you have considered to assess prediction to alloimmunization in patients who receive different type of blood components. Thank you.
Thank you for your question. So first of all, we are the owners and the creators of this tool, so we can change it, develop it as we want. We are thinking about including all the algorithm inside the platform, but also artificial intelligence to improve the care at the individual level, but also run the prediction automatically, for example, to see what are the patients at high risk of mortality, high risk of GFR decline. So it will be in a supervised and unsupervised way. We can perfectly translate in any language encyclopedia, so that's why I put my email address, because we will normally in 3 African countries next year. It's just depending on the fundings. And I want to just to say that I was very interested by what has been said about the HbF here, but it's the same things that the Indian physicians are saying in India for the same reasons. So I'm really interested by the way to what we saw with our own results, but we don't have your experience and as many patients with high levels in HbF, is that the ratio between the F and the S is a very important thing, and the duration state, meaning the MCHC. So if you take these 3 parameters at each single cell level, I think you could have the answer of why some patients with high HbF level could be very severe. And the last point is you were talking about the bridges between the diseases. They are very, very important. When we began using the icudizumab that now everyone uses for the DHTR, the delay hemolysis transition reaction, and it changed the mortality in this complication, it was based on our work on complement activation pathway, but talking with specialists on PNH, and we are even thinking about the NTC3 for the same reasons. And in my lab, we have 3 space programs ongoing, and we are even thinking about the complement activation in the anemia in space for the same reason. So it's important to make the bridges and have the open mind, because finally the pathophysiology can be very common.
I've commented on the name benign hematology, but I remember again in 2019 when I was thrown at this, and this chapter was given to me by MOH. Sickle cell disease and thalassemia were under the rare diseases. And alhamdulillah, with all of the work, we managed to pull the inherited blood disorder out of this pile. The PNH remains there with HUS, but I think it's one of the objectives, inshallah, of the administration over the coming 2 to 3 years is to try to prove this to people as well and bring it out of the pile of rare diseases. So thank you for doing this tonight.
Question in the middle. Yeah, there.
So, Assalamu alaikum. Dr. Ahmed Al-Maiman, pediatric specialist at Diriyah Hospital, Riyadh 3rd Health Cluster. I have a question about transitional care from pediatrics to adult, with the cutoff in this country being 14, 15 onwards. And with respect to the numbers on the screen, what are some of the challenges that we need to be aware of before properly transitioning a young man or young girl with these types of inherited blood disorders?
Are you going to be here tomorrow?
Just tomorrow, yes.
Yes, there is a dedicated session on transition in inherited blood disorders, so I'm glad to welcome you to this one.
Thank you.
Unless someone...
It was just actually part 1 of the question. Part 2 was, do you have any expectations from us, general pediatricians or even the pediatric hematologists, before we transition these vulnerable patients? Thank you.
So the question, expectations from pediatrician. Honestly speaking, that you guys are doing way better job than as adult hematologists. Sorry about that. I don't want to be honestly. Wallahi, يعني أقول I'm an adult hematologist, but I have to honor the efforts that the pediatric hematologists are doing, honestly, because I do recognize that we have a lousy, honestly, transition system. There is probably no system that exists. We're working on this. But at the same time, just based on my experience too, all of the patients that I'm receiving from pediatric colleagues are honestly well managed. And once they get into the adult system, the chaos starts. I think there have to be dedicated clinics for youth, and we have to recognize the age of youth, especially in Saudi, since the transition starts at 14, because transition at 14 is not fair. But we have to recognize the AYA programs that is available. We're trying to work on them. I welcome everyone who is interested in this, because this is one of the things that we really want to work on in the country. The registry is a very good platform to facilitate that. And you guys are doing well. We have to compete with you at one stage. Yes, please, David.
David Roberts from National Health Service Blood and Transplants. That's the blood service in England and also Oxford. But I just wanted to respond to a colleague here who mentioned the importance of antibody measurement. I will be talking tomorrow about genotyping patients and also larger numbers of donors to provide better matched blood. And although that's an innovation, I think transfusion therapy is really a mainstay of therapy in sickle cell disease, and it's underpinned by the sort of initiatives that you mentioned about having a sufficient supply of blood, good information about antibodies available to anyone in the country in healthcare, and also a very good system of returning donors who are well phenotyped to make blood available to patients. So I hope we can talk more about it tomorrow.
Ahmed? Yeah, sure.
Okay. No, me and Rana, we were discussing a number on the board that hemophilia, it is 3,700, keeping in mind that the census of Saudi Arabia is 35 million. 1/3 of them, they are expats, where most of them, they don't have hemophilia. And I know that this number coming from Ministry of Health hospitals doesn't include the other sectors, the private sector, for example. So this number is not going with the constant value of hemophilia in a country. So this is higher number. We suppose in Saudi Arabia to have something like 2,000 plus. So do you have an explanation why the number is high?
I'll tell you something. So this is the end of phase 2. So what we've done before including other patients, other sectors, we went to the national biodata and we tried to integrate it with the system. And those are, the numbers here are not necessarily the patients with the full spectrum of data. It's more of capturing where are the patients. So this is biodata, plus it's not only hemophilia, it's hemophilia and rare bleeding disorder. So it does include von Willebrand and Glanzmann's thrombocythemia. So the others there, because we've included lately in the registry as well the results of the newborn screening. It's a system that is built constantly, so there are lots of sub-chapters and sub-diagnoses as well. You were scared, صح? Yes. Yes, we might take one last question. Dr. Abdullah Zaid, صح? Yeah.
It's partially I've been asked by Dr. Ahmed. It's regarding the numbers. You know, a couple of years ago, they were asking me, what is the thalassemia patients in Saudi Arabia? What was my answer? We have a prevalent, but I don't have numbers, and hopefully the registry will tell us. And here I'm congratulating you, Prof. Hatoun, for this achievement. Really, we are very glad that we have the dashboard of inherited blood disorder. At least we have numbers. But my question is, you know, because this happened a couple of months ago, the numbers from Eastern Province cluster, they collected the numbers mistakenly. They gave a wrong number because they just collected the diagnosis. And you know, sometimes the diagnosis might not be accurate. So, you know, by mistake, you can enter wrong diagnosis. That's why I want to make sure, was this double-checked numbers? Like for anemia, was there somebody who looked at the electrophoresis? For hemophilia, was there somebody looked at the factor level and so on? Was it double-checked?
This is all quality assurance work of the registry, honestly, that we're doing on constant basis. But the diagnosis was built based on identified ICD-10 codes. So this is the method that we've used more than anything else. So upon building the registry, we picked certain ICD-10 codes that covers diseases, and we made sure that traits are not included because sometimes you will find ICD-10. But have we gone patient by patient, HPLC or electrophoresis? We've done this on around 34,000 patients, and those are the actual patient identified at 31 MOH sites with complete data in the system. Okay, so if no further question, thank you so much. Thank you, our moderators and speakers, and thank you. Please, we will have up the QR code. No one is allowed to leave until you scan and do your evaluation, at least for the day. This will help us really to improve, inshallah, and consider lots to come. On the way out, the organizing group, the organizers will guide you to the dinner hall. And thank you so much. See you tomorrow, sharp at 9.